Yes, let's start. Tell me when you're streaming and I'll start. Hello, my dear students. I am Dr. Amrit Nasta, your surgery educator on cerebellum. Please reply. I can see your comments on my phone on YouTube. So if you can see me and hear me clearly, just give me a thumbs up in the chat box so that I can proceed. So I'll just wait for a minute to ensure all you guys are here. You can see me and hear me, just give a thumbs up in the chat box. Yes, perfect. Wonderful. Wonderful. Okay. So before we begin, a few important things that I want you guys to know. Surgery undoubtedly is supremely important. I have handpicked some of the most important topics that you must know at this crucial period. So we are maybe 17, 18 days away, right? So whatever topics I'm going to touch upon are supremely important. At the end of the session, I will give you a list of the kind of topics you should be doing about a week before your exam. So if you're comfortable in surgery and you would have planned in the last 10 days, I'm going to spend half day on every important subject. So in that half day or one day, what topics you must do, I will give you a list of that at the end. All right. I have lined up 30 very important topics for this module. Let's hope we can finish them fast because I don't want to take too much of your time. Also, I understand your exams are close. So for that, you have to reply in the chat box quickly. So whatever question I ask, please reply quickly. And at the end, if there's anything you want to ask, you can wait in the end and ask me more. But the questions that I have lined up for you, let's finish them quickly. And I have tried to touch on each and every component from trauma, general surgery, hepatobiliary. I have included daily updates wherever possible. I have myself personally gone through almost 70% of the new edition. I don't suggest you start hunting for that now. Okay. Don't run behind new Bailey love right now. Stick to your strategy. How much ever time you are giving to surgery, stick to that. Okay. Don't do anything extra. Yes, it's like a rapid revision of the most important topics. That's what Sony is asking. So of the must know topics, the kind of topics that not knowing will make a big difference. So I am only touching on those topics. All right. And of course, you can ask your doubts along the way. So I'm Dr. Amrit Nasta. Let's begin. Let's try to make this a truly rapid but interesting revision. Okay, let's start with something simple. I am going to touch upon every component in general surgery. All from trauma, GI, HPB, Euro, super specialty. The cherry pick topics are the ones you need to know. Right. So let's start with this one and let me know what you think about this. I am seeing your responses in the chat box. So there is a 25-year-old male with alleged history of road traffic accident, injury to the chest and abdomen. Systolic blood pressure was 70, pulse rate was 110. Which of these is the next step? All right. Which of these is the next step? Now, mind you, you're all jumping the gun too fast. But if there was an option instead of MRI, if there was an option of airway assessment, go for airway assessment. If there was an option of breathing assessment, go for breathing assessment. I am not putting too many pitfalls in this, so fast is the answer. But please understand, at this point of time, you are going to follow a simple principle, that is always go for A, B, C, D, E, F. All right, always go for A, B, C, D, E, F. This should be the mindset. Don't jump the gun on going too fast, because I purposely put fast as the first option. If I would have put breathing assessment, obviously you will do that first. So first you will do airway, then breathing, then circulation, then disability. So don't jump the gun is my message to you. Be very precise, because pitfalls, tricks are going to be like this. Of course, it's simply said, systolic BP is low, 70 mm of Hg, which means he is unstable. So you are right when you say unstable patient, you are going to do fast. That is perfect. All right. So you are going to go A, B, C, D, E, F. Now, a few points that you need to know about fast. This is the golden word. Unstable is going to be fast. right? Now, what do we do in FAST? We put our ultrasound at 4 areas: epigastrium, right paracolic, left paracolic, and pelvis. And you can also check the thorax. That is going to be the thoracic spaces. What does FAST tell you? Please understand, the intention of doing FAST is only to identify, does the person require surgery or not? Okay, you are not doing FAST for any clinical diagnosis. You are doing only to identify to do surgery or not to do surgery. That is the intention of FAST, which means anything that you get positive on FAST, the person requires some intervention. That is the intention. Anything positive. Now, what do I see? What am I trying to diagnose? In the first zone, I am going to diagnose pericardial effusion, which implies cardiac tamponade. So if a person has chest or abdominal trauma, pericardial effusion means cardiac tamponade. In the second and third zones, I am looking for free fluid in the right and left paracolic spaces. Right, in the right and left paracolic spaces. In the right side, it means the free fluid is coming from liver or maybe right kidney. On the left side, it is coming from spleen or left kidney. If I see free fluid, patient is unstable, next step will be surgery. That is what I want you to know. Next step will be surgery. And the fourth is going to be free fluid in pelvis. Now the problem is, if I see free fluid in pelvis, I don't know where it is coming from. It can come from anywhere in the abdomen. It can be hemoperitoneum, it can be blood, or it can be a perforation with bile or feces. So on my Instagram, I had put a video, which of these is the drawback? Now, I don't feel they will ask you what is the role of FAST. I feel they have done that enough. Now they will ask you what are the drawbacks. Now, what are the drawbacks? First is it is operator dependent. So if the sonologist is not good, he may miss a diagnosis. It is operator dependent. Second is it has a sensitivity. If the free fluid is less than 100 ml, it will miss the free fluid. But more importantly, it cannot tell you what is the free fluid. Is the free fluid blood? Is it bile? It's not going to tell you what it is. And the fourth is it cannot identify retroperitoneal bleed. This was asked in INI-CET. Retroperitoneal bleeds. Now, in the question that I discussed, one option was retroperitoneal bleed, one option was perirenal collection. As such, even perirenal collections cannot be picked up unless they have exploded into the intraperitoneal space, into the paracolic spaces. So if retroperitoneal hemorrhage was not in the option, the next best answer would have been perirenal collection. All right, but that was the recall. In that scenario, the best answer is going to be retroperitoneal bleed. So be very vigilant about A, B, C, D, E, F. I've told you the F, but all of these components are easy. And of course, it cannot pick up free air in the abdomen or pneumoperitoneum. Free air will be missed. Of course, goes without saying, because air and ultrasound don't go together. If I tell you what is the enemy of ultrasound, air and bone. Wherever there is air and bone, it will come in the way. Anything which is behind hollow viscous, behind intestines, you may not be able to see it. So air and bone are the enemies of ultrasound. Any place where you see this, it is going to be a hindrance. It causes acoustic impedance. Okay. Now let's see if you can handle this one. This is an INI-CET question, but the concept is what I need you to know, and I will make it really simple for you. After today, any question on retroperitoneal hematomas, you will know exactly what to do. And if I set your paper, I would surely put something of this kind. This was INI-CET 2021. Let's see if you can handle this. What is the true statement regarding retroperitoneal hematoma? Zone 3 should always be explored. Mattox maneuver involves some hi-fi things that are written. Medialization of splenic flexure. Vessels injured in zone 1 should be embolized. Pelvic injuries should be explored. Please don't be clean bold. This is a PYQ INI-CET 2021. It's not my own question. Maybe the recall is not exact. I have adjusted the recall a bit, but definitely this has been asked. So let's see what you guys say. I'm interested to know your responses here. Some are saying B, some are saying D. Let's see what Gautam Gupta says. C, B, C, D. Okay. You know, when they set your paper, if there is a topic in which many students are making mistakes, those topics are repeated. If you notice in the last 2-3 years, urethral trauma, bladder rupture has been coming repeatedly. Reason being people are making mistakes in it. So similarly, retroperitoneal hematoma, I can see B, C, D. Everybody has 3 options have been marked equally. That's a problem. So you can say this question is going to come again, or this kind of a question is going to come again, because people are making mistakes in this. Let me make it simple for you. Before you see the answer here, B, C, D, only one of you is right. Nobody has gone for A. I should have put a better option for A. Zone 3 hematoma should always be excluded. B, C, D. Okay. Let me make it simple for you first. Basic concept. You know the zones of retroperitoneal hematomas. Zone 1 is the central zone. All right. Now, when there is a hematoma in the central zone, means in this area, where is the hematoma coming from? The injury is going to be IVC injury or abdominal aortic injury. Right? IVC or abdominal aortic. This much is simple. Zone 2 is over here in the flank. This is zone 2 or flank. If there is a hematoma in zone 2, where has the blood come from? It has come from the kidney. Typically from the kidney. Where does blood in zone 3 come from? Pelvis. Where is this coming from? Pelvis. Interesting one. So this is zone 1. Zone 2 is kidney. Where is the blood in zone 3 coming from? In the pelvis. And you know, nowadays there is a zone 4 also. It's not given in Bailey. There is no zone 4 in Bailey, but nowadays there is a zone 4 also. I'll just tell you for your information that sometimes they will mark a zone in the area of the liver that is zone 4. It is new. It's not there in a lot of books. Zone 4 implies retrohepatic hematoma. Retrohepatic means it is coming from the hepatic veins. They are behind the liver. Retrohepatic. You are saying iliac arteries. No, it's not iliac arteries. Iliac arteries means it can be, but not very common. Why would the internal iliac get injured? Isn't it a little unusual? It is so far in the pelvis. Of all the things, why will internal iliac get injured? Yeah, it cannot be internal iliac. That is such a rare artery. Even if you want to injure it, you can't injure it. Internal iliac embolization in PPH, they do it. That's because it's difficult to do it. So no pelvic trauma will cause internal iliac injury. I mean, very difficult. Yeah, anybody? Zone 3 pelvis means what? When I say zone 3 pelvis hematoma, typically it is coming from pelvic bone fracture of pelvic bone. So ischium fracture, pubis fracture, it is not intraperitoneal. See, mesenteric artery bleed will not cause pelvic retroperitoneum. It will be intraperitoneal. Intraperitoneal is different. We are talking about zone 3 extraperitoneal. Because these are zones of retroperitoneal hematoma. So it is coming from the pelvic bone. So it's typically coming from a pelvic bone fracture. Please be very clear about this funda. This is where we get stuck and we wonder what is going on. This is why all you guys got stuck. Now you have the fundamental clear what each zone implies. Now it becomes very easy. IVC injury or abdominal aortic injury, you will always explore. All right, you will always explore. Mind you, always explore. This is in a stable patient. These zones are going to be identified not on FAST. That's why I put the question on FAST, because FAST will not pick up these injuries. So FAST will be negative. So whether patient has to be stable. You have done CT and you have found these zones of hematoma. So patient is stable, still you are saying always explore. Okay, so central zone hematoma, don't go on this thinking that patient is stable. Should I wait for it? Patient wait for deterioration. You know, that is our conventional teaching. Trauma, wait for deterioration. Central hematoma, always explore. Very clear. This is point number 1. For flank injuries, if there is a renal bleed, you may explore. Okay, you may explore. If not, you may be able to angioembolize. Okay, so for zone 2 injuries, You may explore or angioembolize. When will you do it? If the bleeding is expanding hematoma. That means the kidney is continuing to bleed, expanding hematoma. If the hematoma is expanding, you may explore or angioembolize. If not, do nothing. And for zone 3, the one where you got stuck, there is a pelvic bone fracture. Ideally, you should not explore. So you avoid exploration. Then what do you do if he's bleeding? If there is a pelvic hematoma, extraperitoneal, not intraperitoneal, retroperitoneal, what should you do if there is a pelvic hematoma, pelvic bone fracture? But we never explore zone 3. You avoid, yeah, you should avoid as much as possible because it's a very inaccessible zone. So what should you do if he is bleeding and you should not explore? Then what's your alternate if he is bleeding? You can do two things. The first thing you are going to do is you are going to stabilize the fracture. You have to stabilize the fracture. 99% of the times the bleeding will stop. Absolutely right, Ramesh. You will first put a pelvic binder. If that doesn't work, you will put an external fixator. All right, you will put an external fixator after stabilizing the patient. That's how you treat pelvic bone fractures. External fixator. Only if nothing works, you will do surgery. All right. So put a pelvic binder or an external fixator, or worst case scenario, you can angioembolize if he still bleeds. So the key word is avoid exploration. What about zone 4? Anybody? You think what you are going to write about zone 4 while I tell you about the answer to the MCQ. Now you know it's possible. Zone 3 hematomas should always be explored. Absolutely wrong. They should rarely be explored. We don't know about Metox maneuver. Vessels in zone 1 should be embolized. Absolutely not. Zone 1 should be explored. Pelvic trauma should be explored. Absolutely not. So by elimination, you got the answer, Metox maneuver. Even if you didn't know Metox maneuver, by elimination, you got the answer. That involves some medialization, something. Please understand, the fundamental is, why have they divided these zones? I always teach my students, whenever there is a category, a classification, there is a reason for this classification. Why did they call this zone 1 and this zone 2 and this zone 3? It's not because of anything in anatomy. That central is most common, followed by flank, followed by pelvic. Absolutely not. It's because how severe the bleed is in each zone. Which is why zone 1, always explore. Zone 2, may explore. Zone 3, avoid exploration. The fundamental is, as I'm going from zone 1 to zone 2 to zone 3, my need for surgery is becoming lesser and lesser and lesser. That's why they are zone 1, zone 2, zone 3. And there is no hypothetical nomenclature over here. There is a reason for everything in surgery. Every classification that you study, there is a reason for it. Why it is put in this category? It's telling you the severity of bleed. Zone 1, always. Zone 2, may. Zone 3, avoid. I'm waiting for the answer. What do you do for zone 4 injuries? Retrohepatic IVC or hepatic vein injury. What are you going to do? Explore, angioembolize, may explore, or something else? Think about it. It's an interesting question. It's not there in the books. I mean, it's there, but it's in very fine print. So now, while you think about that answer, let me tell you these two important things. Whenever I do a laparotomy, and this is important, have a good look at these images. They will come in your exam. They will come in your exam. These two images. Prerna saying ligate vein. I don't know which vein are you planning to ligate. In liver, put pressure. You mean do surgery. Pelvic fractures cause large blood loss. So you are stopping the blood loss. You will replace the blood. The intention is, are you going to operate or not? It is telling you need for surgery, not severity of bleeding. And aortic injury is more severe than pelvic injury. Let's be very clear. I think I'm teaching in English only. Maker, right? So push, Pringle, black. No, you're talking about liver injury. I am asking you, do you need to explore, or you need to wait, or you angioembolize? What do you do? The answer is going to be damage control surgery. All right, answer is going to be damage control surgery. This is the answer. Retrohepatic IVC injury and hepatic vein injury, damage control surgery if unstable. If unstable. If stable, observe. Liver injuries are going to be observed unless he is unstable. These are identified on CT. Yes, they are not identified on FAST. Of course, they are CT diagnosis. Now, retroperitoneal trauma, whenever I do a laparotomy, please understand, I cannot see the aorta or the IVC. They are not going to be seen. So what I have to do is, the IVC and the aorta are very far behind. They are just in front of the vertebra. So when I open the abdomen, I don't see them. They are right at the back. What I am going to see in front is going to be the small intestine over here, the colon over here. I see all that. So to reach them, what I have to do is I have to free the colon, free the small bowel and push it medially. Okay, I have to free the colon, small bowel and push it medially. Which means if I want to see the IVC, now IVC is on the right side, as you see over here. What I have to do is I have to free the ascending colon. It's not left colon, this is right colon. I have to free the ascending colon and push it medially. Go behind it, then I will see the kidney and the IVC. So what I have done is I have done right viscera. So all my right sided viscera, cecum, ascending colon, right side of small bowel, I have pushed them medially. This is called right medial visceral rotation. And right medial visceral rotation, this is called Cattell's maneuver. Okay, yeah, cattle brush maneuver. So right medial visceral rotation, Cattell's maneuver, it is for IVC exploration. Similarly, if I want to see the abdominal aorta, I will have to move the left-sided viscera, descending colon, sigmoid colon, all of these I have to push them medially, go behind, then I'll see the abdominal aorta. Right, then I'll see abdominal aorta. In that case, this is called left viscera is going to be medially rotated. Left visceral medial rotation. Also called as Mattox maneuver. I am telling you, you are going to get a question on retroperitoneal hemorrhage. They are done to death with the same ABCD. Now they will ask you retroperitoneal. Now they are not going to ask you intra-abdominal. So this is Mattox maneuver. And Mattox maneuver is to identify abdominal aortic injury. Right, abdominal aortic injury. Please be very clear about these maneuvers and these images. When patient is unstable, if FAST is negative, you have to identify why is the FAST negative. Is the trauma in the abdomen or somewhere else? If it is in the abdomen, even if he is even if FAST is negative but he's unstable, you will have to resuscitate and operate because FAST will not pick up this. But it's very rare. Abdominal injury, FAST negative, and he's unstable. He remains unstable. Difficult. Chances are very less, like a retroperitoneal injury. But yeah, unstable. If there is no FAST, go for exploration. Go for it. If nothing else is injured. Now come to this. Again, popular topic because students make mistakes in it. Very simple fundamentals. After today, you will never ever make a mistake in these kind of injuries. Never. I'll give you a very simple pathway. 3-4 things you have to see. You will get the diagnosis. 3-4 things. Nothing too complicated. In 5 minutes, these injuries, never in your life you will have a problem. They are based on anatomy. Give me 5 minutes to help you with this. Perineal injury comes emergency department. Blood at meatus, unable to pass urine. Bladder is not palpable. What is the next step? Suprapubic aspiration, insert Foley, send home, wait for bladder to fill. Tanmay Murur is answering. Tanmay Murur is already in MD medicine. I wonder why he's here. Okay. Wait for it to fill. Yes, Karan Singh, I see a lot of familiar names. Good job. Okay. Simple. Very simple. Basic anatomy, and then you will get the answer. 3 things you need to know in this whole gamut of urethral and bladder ruptures. In fact, urethral rupture, they had asked in AIMS, the recent AIMS, they asked penile urethral rupture. Students got stuck there also. Why penile urethral rupture? It means the same thing. No rocket science. I will make it very easy for you. This is the kind of topic, once you know, you should be done with it. And how much ever they twist and turn, you should never ever have a problem in these kind of topics. Never ever. My students should not. Those who have learned from me can never have a problem in this. So I'm talking about male urethral rupture. So this is prostatic urethra. This is the pelvic floor, membranous urethra. This is the bulb, and this is the penile urethra. Okay, this is penile urethra over here. They had asked penile urethral rupture in the last exam. The students got stuck. Now understand, somewhere here is going to be the pubis in front. Behind here is the rectum. This is where people don't get the orientation. Behind here is the rectum, and this is the anal canal. And this is going to be the anal verge. Now understand, behind the anus, this is the ischio-rectal fossa. Behind and in front over here, there is going to be scrotum and there is going to be perineum. Okay, there is going to be perineum. Here, the penile skin will be continuous with the pubis. Now be very clear. Simple things. Urethral ruptures can happen in two ways. Urethral ruptures, either the posterior urethra will rupture or the anterior urethra will rupture. Okay, posterior or anterior, have no doubt. Be very clear about this. Posterior urethra is this urethra, this part, prostatomembranous. Okay, this urethra. Anterior urethra is everything in front, bulbopenile. Usually it is the bulbous. Penile urethra rarely ruptures. Bulbous urethra ruptures very easily. If I have an injury over here to the pubis, the injury will go over here and cause a tear in the urethra at the prostatomembranous junction. When this urethra will rupture, urine will leak over here in this area. What is this called? Where the urine leaks. So if there is a posterior urethral rupture, it will be a tear of the prostatomembranous urethra or posterior urethra. Where will the urine leak? In prostatomembranous urethra? Please answer quickly. Further, the anterior urethral injury will happen if there is a blow to the perineum. So if I get a blow over here, the force will go reach the bulbous urethra and this urethra will rupture. And when the bulbous urethra will rupture, over here, the urine will leak in this space. Simple anatomy. Right. So what is this space called? Above the pelvic diaphragm. Yeah, excellent. It's cave of Ritzius. So if there is a posterior urethral rupture, the urine leaks in the cave of Ritzius. First, this is all you need to know. Cave of Ritzius. If the urine leaks in the cave of Ritzius, many times there is a ligament which folds the prostate to the pubis that tears. So there is a tear of puboprostatic ligament. I am writing over here PP, puboprostatic ligament, that will tear. Because the puboprostatic ligament tears, the prostate becomes free and you get a floating prostate, also called as Vermeulen sign. You get a floating prostate. If the anterior or the bulbous urethra ruptures, the urine will leak over here. This is called superficial perineal pouch. So here the injury is happening to the perineum. Urine has leaked in the superficial perineal pouch. And because it is leaking over here, urine collects over here, then it goes into the scrotum, then it goes into the penis. So urine collects superficial perineal pouch, scrotum, and penis in the subcut of these organs. The question in INI-CET was, if there is a penile urethral rupture, where does the urine not leak? And the options were base of penis, base of scrotum, superficial perineal pouch, deep perineal pouch. Answer was deep perineal pouch. No rocket science. Fundamental has to be clear. Okay, so urine has leaked over here. So based on the examination findings, you can predict its anterior or posterior urethral ruptures. As simple. Now, what will tell you it is urethral rupture? These are the golden words. Remember these golden words. There should be a trauma in the pubis or perineum. The trauma should be here. And after the trauma, the patient should be unable to pass urine. So there should be inability to pass urine. There should be blood at meatus. If you see blood at meatus, it is urethral rupture. There is nothing else that will cause urethral rupture except blood at meatus. And the third thing which will happen is, since he is not passing urine, the bladder will start distending and later the bladder will be palpable. He'll have a palpable bladder. You see these things, these three typical findings: inability to pass urine, blood at meatus, palpable bladder, urethral rupture. Job is done. The most important is blood at meatus. But now they are becoming very smart. They will not give you this finding, blood at meatus, unfortunately. If you see this, they ask you what is the next step. What will be your answer? You see these findings, palpable bladder, what is the next step? You should be absolutely clear about urethral and bladder ruptures. After learning from me, you can never have a problem. So what is the next step? Blood at meatus, palpable bladder, and unable to pass urine after a trauma at the pelvis. The next step is going to be, I want to know, is it posterior or anterior urethral rupture? Clinically, I can make out. Clinically, if the prostate is floating, it is posterior. If there is a perineal hematoma, if there is blood collected in the scrotum and the penis, I know it is anterior urethral rupture. But to confirm, yes, absolutely right, I'm going to do a retrograde urogram. Retrograde urethrogram. And that will tell me what it is. But let me tell you, whether I do RGU or RGP or not, the management is going to be the same. There is only one management. The management is going to be suprapubic cystostomy for both. Clear? Suprapubic cystostomy. Do an SPC. You wait and wait and wait for 2 to 3 months. What will happen is wherever the tear was, posterior, anterior urethra, it will eventually heal by fibrosis. After it heals by fibrosis, you are going to treat the stricture electively. Eventually, you are going to treat the stricture. So whatever you are going to do, you have to do SPC and wait. Nothing in emergency, nothing hi-fi. Right? So that is about urethral rupture. Now go to the question. When they say perineal injury, you should obviously think of anterior or bulbous urethral rupture. Alright, think about it. Blood at meatus, urethral rupture, unable to pass urine. The problem here is bladder was not palpable. Why is the bladder not palpable? I mean, isn't it unusual? If the urethra is ruptured, shouldn't the urine collect in the bladder? Shouldn't it be palpable? I just told you it should be palpable. Yeah, so why is the bladder not palpable? What does it tell you? And what are you going to do? And what should be the best next step or the next best step? Fundamentals have to be clear. I am happy we are having this session because I am so sure these kind of topics will keep coming again and again, and students will make the same mistakes again and again and again. Why is the bladder not palpable? There are two reasons. One is it has just ruptured. It's too early. It has just ruptured. So bladder has not gotten filled with urine. So that's why the bladder is not palpable. Or there is a combined rupture. There is a combined rupture. It's possible that there can be a rupture of the urethra and the bladder. But whatever said and done, if I have to do SPC, suprapubic cystostomy, if this has to be done, the bladder has to be full. If it's not full, I cannot do SPC. That is why the answer here becomes wait for bladder to fill. All right, the answer here becomes wait for bladder to fill simply because I have to do a SPC. If the bladder doesn't fill, I wait for 1 hour, 2 hours, bladder is not filling, and I'm wondering what the hell is happening. In that case, I am going to do retrograde urethrogram and I will realize there is a rupture of both bladder and urethra. If bladder and urethra both are ruptured, then I will have to do a surgical SPC. Surgical SPC means I'll have to do surgery, find the bladder and do the SPC. But this is rarely ever required. Surgical SPC is going to be required if there is a combined rupture, bladder and urethra. All right, if there is a combined rupture. Otherwise, wait for bladder to fill, do the SPC, and then after 2-3 months, when patient is all right, that is when you are going to do a urethral reconstruction for the urethral stricture. This is the image. Since they ask these kind of images, I just want you to get oriented with the anatomy. When I do an ascending urethrogram, so this is going to be the penile urethra. The curved urethra over here, which you can also see over here, this curved urethra, this is the bulbous urethra. All right, that's why it's called bulbous. It's shaped like a bulb. It is curved. It rests on the perineum. Anything in the area of the pubic symphysis, the urethra in the area of the pubic symphysis over here, this is going to be prostatic or membranous. All right, it's going to be prostatic or membranous. So if you get this image and they ask you what is the site of urethral rupture, in this case, the answer is going to be membranous urethral rupture. This is bladder neck, prostate will be over here, below it will be membranous, right? So if you are confused whether it is prostatic, membranous or bulbous, remember bulbous is this curve. The curved urethra is the bulbous urethra. Just below the bladder neck is going to be prostatic or membranous urethras. Please now don't make any mistake in urethral injuries. After today, you can never make a mistake in urethral injuries. Never ever. All right. So there is a 30-year-old patient who presented to the casualty after an accident. He had some chest trauma. His pulse is this, his BP is this, his respiration is this, neck veins are showing something, air entry is absent. What is the next most appropriate step in the management of this patient? Vedire Anirudh, I will give you a list of must-know topics at the end of the session. I have written it down. It's the last 2 slides. In each system, 10 must-know topics. I have it written down. You can see it at the end of the session. The last 2 slides are that only. Yeah. What is the next most appropriate step in management? Thoracotomy, pericardiocentesis, pleurodesis, chest insertion. Okay. So yeah, you are calling it tension pneumothorax. That's wonderful. If the best answer would have been needle thoracocentesis, but that's not there in the option. The best answer would have been needle thoracocentesis, and mind you, it is put in the 5th intercostal space in an adult, in the triangle of safety. Not 2nd space, it is put in the 5th space, in the triangle of safety. So answer is going to be needle thoracocentesis or needle thoracotomy, but that's not there in the option. So the best answer here becomes chest drain insertion. Okay, it is a tension pneumothorax. I will tell you why. But let me ask you another question. If there is, what is the actual next best step? If I put the needle in the 5th space, I know it's a tension pneumothorax. I did a needle thoracotomy, but it didn't decompress the thorax. He still is dyspneic. He is still hypotensive. I put the needle, nothing happened. What do I do next? Think about it. Needle thoracotomy did not decompress the tension pneumothorax. What is the next step? This is there in Bailey 20th edition. It's also there in 27th edition. I just read it because I've just recorded the trauma lectures for CBA. So I had just read all these things. No. He has tension pneumothorax. All these findings, same patient. So he is having distended neck veins, air entry is absent. You put the needle in the 5th space, but it didn't decompress. He's still hypotensive. What do you do next? Immediate thoracotomy for a tension pneumothorax. He'll die before that. Transesophageal echo. Absolutely wrong. All the stalwarts are in my class today. Sharayu, Vaishnavi, Prakriti, all Neha. They are all my old students. I expect you to give me some insight into this. Some insight has to be there. Think about it. It's not immediate thoracotomy. It's not one of these options, unfortunately. It's not, and it's there in Bailey. Pericardiocentesis, change in position. How is that going to? Chest drain instead of needle. He will die before you put the chest drain. There is something else you do. There is some rescue maneuver where needle thoracotomy fails. Anyway, what I want you to understand is 3 topics which are going to confuse you always. Tension pneumothorax, cardiac tamponade, and massive hemothorax. Okay, and why I will tell you. All of them are going to come with chest trauma. So in all of them, the history will be chest trauma. And in all of them, the patient is going to have hypotension. Okay, patient is going to have hypotension. Chest trauma, hypotension. It will mean one of these things. How do you, tube thoracostomy, no. Intubation, no. VATS, no. Before you do intubation, VATS, patient is dead. Okay, He's dead before you do any of those maneuvers you are saying. There is something you are going to do. Think about it. Anyway, now how do you differentiate them? The key points. Please understand what words you should look for in the MCQ. One word you should look for is air entry. In tension pneumothorax, air entry will be absent. In massive hemothorax, air entry will be absent. In cardiac tamponade, air entry will be normal because there is nothing in the lung. Okay, so air entry will be normal. Clue number one. Clue number two, you are going to look for on percussion. What note do you get? In tension pneumothorax, golden word, you will get hyperresonance. Okay, hyperresonance. In cardiac tamponade, percussion should be normal. Resonant note. In massive hemothorax, you should get a dull note. And the third clue is you are going to look at the neck veins, JVP. In tension pneumothorax, JVP will be elevated. In cardiac tamponade, it will be elevated. In massive hemothorax, because there is hypovolemia, JVP will be low. All right. This will segregate these three similar looking scenarios. This will segregate the clinical scenarios based on these findings. Anesthetists are also coming for my class. That is wonderful. So once I have diagnosed this, then I will tell you about management. Tension pneumothorax, I told you, needle thoracotomy. So first you do needle in the 5th intercostal space, then you do X-ray, and then you put intercostal drain. For massive hemothorax, you will straight away put intercostal drain. What is the treatment for cardiac tamponade? So patient has Bextrade. What is the next step? You confirm delivered fast. There is cardiac tamponade, fast proven. What is the next step? What is the management over here? After you have done fast and it has proven, it's a cardiac tamponade. Come on, guys. Please don't. Not in trauma. My students are A1 in trauma. To learn trauma for me, you can never make a mistake. What is the next step? If I have diagnosed cardiac tamponade, pericardiocentesis, unfortunately, no. The answer is going to be thoracotomy. Remember this. This is given in Bailey. Thoracotomy or sternotomy. And basically, this has to be done by a cardiac surgeon. Thoracotomy and surgical control. Means surgeon has to go inside, open the pericardium, drain the clot, and then he is going to control the hemorrhage. Next step is thoracotomy, not pericardiocentesis. 20th edition of Bailey has given it in bold. Bold, I'm telling you. Needle thoracocentesis is avoided. It has no role anymore. You are not going to put the needle to decompress a cardiac tamponade anymore because it's a clotted blood. Putting needle and aspirating, no blood will come out. Okay, nothing will happen. You have to do surgical control. Make a note of this. It's not my answer. It's there in Bailey and Love. And he's put it in bold. This class is Bailey updates. This is the Bailey update. This is what I want you to take. Anyways, last question over here. Tension pneumothorax, you put the needle, patient remains hypotensive. It didn't work. Remains hypotensive. That means maybe he is obese, his chest wall is very thick. Maybe the needle didn't reach. It's not getting decompressed. It's tension pneumothorax. If he remains hypotensive, he remains breathless, he's remaining hypoxic. The next step is what is given in Bailey. Answer is finger thoracotomy. Okay, finger thoracotomy. If this is there in the option, and this is not there, go for finger thoracotomy. Finger thoracotomy means quickly he cuts the skin subacute muscle with the finger. He opens the pleura. Once the pleura is opened, he puts the finger and drains the pleura or the pleural space. Finger thoracotomy. It will confirm it's a pneumothorax and it will also take care of the tension. And then he can put the ICD around it. No problem putting the ICD. But if needle thoracotomy fails, next step is finger thoracotomy for tension pneumothorax. All right. So that is about tension pneumothorax and the other differentials of tension pneumothorax. Now come to this one, a concept which students struggle with a little bit. I'll tell you the golden words because topics like stab, retroperitoneal injury, they are the ones which are going to come again and again. Patient with a stab injury, vitals are stable. This is the image. What is the next best step? Investigation, IV fluids, wait and watch, laparotomy. Digvijay is saying laparotomy. Wow, okay. Come on quickly. I am on slide number 14. Please help me reach slide number 68. Last 3 slides are must know topics. Please help me reach slide number 68 fast so that you can go back to studying. Is this same as emergency room thoracotomy? I don't know in what context you asked that. Okay, again, A, B, C, D. Pranati is saying A, Shivang is saying C, Akash D, Gautam B, D, A. Wow, amazing. A, B, C, D. Okay, let's make it simple. Let's make it very simple. They are saying vitals are stable. All right, vitals are stable. You see some wound over here. Why are you doing exploratory laparotomy? What is the role of exploratory laparotomy? This is not going to be the answer. Okay, patient stable. Please don't jump to exploratory laparotomy. There are scenarios. I told you, unstable, fast surgery. Stable, further investigation. If there was a choice where they told you further investigation, the best answer would be CECT abdomen. This is the best answer, CECT abdomen. So golden words, stable, abdominal trauma, answer is CECT. Unstable, fast, no rocket science. If he was unstable, you would have done laparotomy. Then the answer would have been IV fluids and laparotomy. So here the answer is stable, further investigation, CECT abdomen. Now what I want you to know is for penetrating trauma, simple thing, penetrating trauma, there are only 2 things. Either you investigate further or you do laparotomy. So when will you do laparotomy without doing any CT? Laparotomy straight away. Straight away you will do laparotomy. No need to do CT, PT, PT. Straight away laparotomy. First indication, of course, if he is unstable. Unstable, penetrating trauma, laparotomy. No 2 questions asked there. But if he is stable, then what are you going to do? When will you do laparotomy in a stable patient? I'm telling you. So if he is stable, you will do laparotomy if he has features of peritonitis. Of course, if he has rigidity or anything. Peritonitis means some bowel is perforated, operate, no need to do CT-PT. Or if he has what is called as evisceration. Evisceration means intestines are coming out. You can see intestines in the wound. Intestines or other viscera are visible. What the students told me was, some of them said, in this image, some structures were coming out. So if something is coming out from this wound, laparotomy. That means evisceration. If something is coming out. And the third scenario, where you will typically get stuck, that is going to be gunshot. If there is a gunshot injury, again, no need to do CT, straight away go for laparotomy. So these are the indications for straight up laparotomy in penetrating trauma. If all of these are missing, if none of these are present, none present, all of these are missing, then the next step is going to be, don't straight away go for CT, then the next step is going to be explore the wound. Okay, I'm giving you the pathway. Next step is going to be explore the wound. If you explore the wound and the wound is superficial, superficial means subacute only, subacute muscle, nothing too deep. If it's superficial, then you will suture and discharge. Suture and send home. If there is a breach of peritoneum, then you are going to do CECT. All right. Absolutely be clear about this. Absolutely be clear. Multiple wounds, yes, same protocol. Multiple stabs. If any of these features are there in any of the stab, you are going to do surgery. If not, explore each wound. Explore. If there is peritoneal breach, CT. If there is no breach, nothing needs to be done. Assess him overall for other injuries. If there is nothing stopping him, you can send him home. All right. So in this scenario, wait and watch after dressing could have also been right, but it does not fit better. Okay, best answer here is further investigation. All right. So this is the pathway. It's not my pathway. This is ATLS pathway. It's not my own pathway. You see, if there is no danger sign, he is stable, no peritonitis, no evisceration, then nothing. Then check the wound. If the wound is superficial, close the wound, send him home. If the wound is deep, deep means breach of peritoneum, then do CT abdomen to assess for injury. And whatever you get on CT, you decide based on that. Right? So, interesting topics that we did in trauma: retroperitoneal injury, chest trauma, ABCDE, penetrating injury, and urethral rupture. 5 super important topics. Super important topics. What if the knife is impacted? If the knife is impacted, you have to take him to the OT, give him anesthesia, remove the knife and see what's wrong. If he's stable, do an imaging and then take him to OT because you have to remove the knife eventually. Okay. Now come to some general surgery topics. Few only I'm going to touch on in each. The recurrent laryngeal nerve is at greatest risk of injury at what site? This question has never been asked. It's there in Bailey. Never been asked. And the answer is word by word from Bailey. Lower pole, Berry's ligament, tubercle of Zucker candle, or Beer's triangle. Some of the landmarks you need to know. In thyroid, the important topic is complications of thyroidectomy. Anatomy and complications of thyroidectomy. Take my word for it. So, BC, A, some have given A, Meet Patel says B. Isn't it E fast irrespective of stable or unstable? That is after ABCDE, yes. Berry ligament. Lower pole. Okay, the answer here is Berry's ligament. Okay, answer is Berry's ligament. It's a factual question. If they ask you most common nerve injured in thyroidectomy, most common nerve injured, it's a little ambiguous, but go for superior laryngeal nerve. The external laryngeal nerve, branch of superior laryngeal nerve, more than recurrent laryngeal nerve. Okay, if they ask you. Now, some points about anatomy that you need to know. Why it is the recurrent laryngeal nerve and what is this Berry's ligament? Look at it like this. In a cross section, if you look at the thyroid like this, it's all related to anatomy. If you look at thyroid like this, it has a fascia around it, pretracheal fascia. This pretracheal fascia gets condensed posteriorly. Okay, so this pretracheal fascia gets condensed posteriorly. This is the Berry's ligament. It's a pretracheal fascia which is posteriorly condensed, which you can see over here. This is Berry's ligament, this whole structure over here. Now, the recurrent laryngeal nerve runs close to the thyroid in the Berry's ligament. It is actually posterior. That is why it will get injured when I am lifting the thyroid from the Berry's ligament. All right, it gets injured when I am lifting the thyroid from the Berry's ligament. So Berry's ligament, within that is the recurrent laryngeal nerve. When I am lifting it, when I am cutting it, the nerve can get injured. How do I reduce the risk of injury? Anybody? Reduce the risk of injury to recurrent laryngeal nerve. What intraoperative steps do I take to reduce the risk of injury? Think about it. I will tell you what is Beer's triangle. You may have learned this in anatomy. It's a triangle where the anterior boundary is the recurrent laryngeal nerve. The superior boundary is the inferior thyroid artery. And the posterior boundary is the common carotid artery. This is the Beer's triangle over here. So it is bounded by recurrent laryngeal nerve, inferior thyroid artery, and common carotid artery. Yeah. How do I reduce the risk of injury to recurrent laryngeal nerve? Techniques. Preserve a strip of thyroid tissue. No, nobody does that. Diya Kasargod. I wonder why you would say that. Nobody leaves behind thyroid tissue anymore. Anyways, it's in the Berry's ligament. Trace the Berry's. You have till where? Till the larynx. No. You are going to do 2 things. One is you will avoid use of monopolar cautery. You will avoid use of monopolar cautery, because if I'm cutting the varus ligament with monopolar, the current can spread and injure the recurrent laryngeal nerve. Second thing is I use nerve monitors, intraoperative nerve monitor. All right, intraoperative nerve monitoring. So these are the important things that I do to avoid injuring recurrent laryngeal nerve. Let's move on. Yes and no question. This is a PYQ. This was asked in INI-CET. Which of these are not, which of this is not a component of MEN3 syndrome? Yeah, they love asking MEN syndrome. I hope you know the important components. Which of these is not a component of MEN syndrome? Adenoma, megacolon. First, you need to know what is MEN3. You need to know what is MEN3. Is there even such a thing as MEN3? Or is it a misnomer? Okay, easy question. All of you know this very well. I wonder from where. Where have you learned all this? So MEN3 is actually meant to be. It's meant to be. All right. Answer is parathyroid adenoma. Now I'll tell you the key things about each of the MEN syndrome. Just the key things. In MEN1, the rule is PPP. We have a lot of P's today. So the rule is PPP, pituitary adenoma, parathyroid hyperplasia, and pancreatic endocrine tumor. All right, PPP. Yeah, Zenab ma'am. Let me. I will see what Zenab ma'am has not taught you. Let's crack the code here. Pituitary adenoma. What is the most common type of pituitary adenoma? And what is the most common pancreatic endocrine tumor? Let's see if Zenab ma'am has taught you that or not. PPP. And the other. सारे सब वही से लिए है sir. So pituitary adenoma, the most common type is prolactinoma, another P. Life becomes easy when we are in a sea of P's. So prolactinoma, and pancreatic endocrine tumor is gastrinoma. Okay, it's not insulinoma. Overall, most common pancreatic functional endocrine tumor, functional, is insulinoma. But in MEN1, it is going to be gastrinoma. All right, so that is about MEN. Now MEN2 have two things in common. Both the MEN2 have two things in common. One is medullary thyroid carcinoma, other is pheochromocytoma. So this is common in both the MEN2. That's why they are grouped under the same MTC and pheochromocytoma. But in 2A, also you are going to get hyperparathyroidism or hyperplasia of parathyroids. Okay, parathyroid hyperplasia. So hyperparathyroidism is MEN1 and MEN2A. And 2B is the rule of M, megacolon and marfanoid habitus and mucosal neuromas. All right, and MEN2B is also called MEN3. All right, MEN2B is also called MEN3. So this is MEN2B or MEN3, right? Mucosal neuromas. What is the, let's see if Zenab ma'am taught you this. What is the inheritance pattern of MEN1, MEN2A and MEN2B? Inheritance pattern. I don't know if she taught you this or not. I don't want to know the genes. Everybody knows the genes. Menin gene, RET gene. What is the inheritance pattern of MEN1, MEN2A and MEN2B? Okay, think about it while we move on to the next one. Something very fundamental. Meet saying autosomal dominant for all. Is it for all? Or it's different for MEN1, MEN2A, MEN2B? All are AD. Why would you say that? Okay. 45-year-old female underwent thyroidectomy. See, I have put two questions on complications of thyroidectomy because I personally feel this is going to come. There is perioral numbness on day 3. What is the next step? Free T3, T4, calcium phosphate PTH, RAI scan, or thyroid function test. Okay, yeah, it is calcium phosphate and PTH. But what has happened? Why are you checking PTH levels? Why are you suspecting hypoparathyroidism. What is the reason for hypoparathyroidism? Yeah, why hypoparathyroidism? What is the reason for it? Just because I did a total thyroidectomy, I'll get hypothyroidism, hypoparathyroidism. What is the reason? Parathyroid removal. Yeah, it's not parathyroid removal. Please understand, I have 4 parathyroids, right? I have 4 parathyroids. It is not possible to remove all 4, even if I want to. Okay, even if I want to remove all the 4 parathyroids, they are not going to be removed because I will have to hunt for them. Understand, these lower parathyroids, they are present anywhere. They are very abnormal in their location. So hypoparathyroidism is not because of accidental removal. It is not. It is because there is an artery which runs over here, which supplies the lower pole of thyroid, which also supplies the parathyroids. Similarly, there is an artery which runs over here, which supplies the lower pole of thyroid and also the parathyroids. This is the inferior thyroid artery, right? Inferior thyroid artery. The old teaching was ligate the inferior thyroid artery away from the gland. If you read anatomy books, they tell you ligate it away from the gland. When you ligate it away from the gland, all the 4 will become ischemic. So the cause of hypoparathyroidism is ischemia of parathyroid. It is ischemia of parathyroid, right? And not accidental removal. I am telling you, even if you want to remove it intentionally, it doesn't happen. So forget accidental, out of question. Which is why if you read Bailey now, what Bailey says, how are we supposed to ligate it? You are supposed to ligate it individually. So each of these branches are going to be ligated individually. So you ligate the branches individually, close to the body, individually, close to the gland. Okay, close to the gland. The reason is I want to avoid ischemia of hypo or hypoparathyroidism, right? Because you want to avoid ischemia. So you ligate the inferior thyroid artery close to the gland. It is called ligation in continuity. Remember these words, ligation and continuity. So if they ask you ligation and continuity applies to ligation of what? Inferior thyroid artery. They'll give you these options: inferior thyroid artery, superior thyroid artery, internal jugular vein, middle vein, something like that. Most of them will mark middle thyroid vein because you have been taught that is the first structure you have to ligate. Nobody even sees middle thyroid vein in today's day and age. All right. So this is the fundamental. One last question on this. What happens, or rather, what should I do if I accidentally have all the 4 parathyroids removed with the thyroid? Okay, what will happen if I accidentally remove all 4 parathyroids? No, it doesn't increase the risk of recurrent laryngeal nerve injury, Buddha-priya. It doesn't. Old teaching. New teaching is very different. So what should I do if I accidentally remove? One of you were saying, na sare nikal diye. If I accidentally remove all 4 parathyroids. So I removed the goiter and I saw on my goiter, I saw all the 4 parathyroid glands. And I'm like, oh my God. One was here, one was here, one was here, one was here. All 4 are in my hand. Auto-transplanted where? Where do I put it? In the forearm. Where do I auto-transplant it? Non-dominant hand brachioradialis. Wow. Non-dominant hand brachioradialis. SCM. Okay, please remember, if they are accidentally removed, means I did not remove them intentionally. If I remove them accidentally during thyroidectomy, if I have removed them accidentally, I will implant them in the neck in the same incision. I will reimplant them in SCM, and all of them, all I will reimplant. This forearm business is where I have removed them as a part of parathyroid hyperplasia. Okay, that is for parathyroid hyperplasia. Then I'm only removing the parathyroids, and I want to keep some behind. That I put in the forearm. But why do I put it in the forearm, not in the neck? Why reimplant in the forearm if I have removed all the 4 intentionally in hyperplasia? Here, this is accidental removal. So I put all 4 of them back in the SCM because they are not diseased. When I remove diseased parathyroids, little bit I put back, not in the neck, in the forearm. Why? Why different? Put both, either in the neck or in both scenarios, put in the forearm. Why here I can put in the neck, and here I'm telling you put all 4 back. No little bit of pieces. But in hyperplasia, where he has hyperparathyroidism, I put small pieces. There is a value for that. 1 to 2 mm, 8 to 10 pieces in the forearm. Absolutely right. Because sometimes the little pieces that I put back, they can undergo hyperplasia again. So if they are diseased parathyroids, if I put some back, the graft, what I put back, can undergo hyperplasia. And if that happens, he will get hyperparathyroid again. Easy to remove from here. Excellent, excellent. Easier to remove if there is recurrence. So be clear about these fundamentals. You don't have to mug these things. If you understood this, how much ever they twist these kind of topics, no, you will never make a mistake. Never in your life. There is a test. How do I prove recurrence from forearm hyperparathyroid? What is the test for proving that? If the graft undergoes hyperplasia in the forearm, what do I test? What is it called? Okay, think about it while you answer this. Which of these has the least lifetime risk of breast cancer? This I have put because there is a daily update about this. Yeah, Tanmay knows. It is called Casanova test. Absolutely right. Casanova test is for detecting hyperplasia of the graft. Yeah. Which of these mutations has the least lifetime risk of breast cancer? I'll give you some update. I have also posted it on my Instagram. Most of you are saying BRCA1. Why would you say BRCA1? I mean, come on. If I were you, I would have never marked any of the BRCAs because BRCAs are having risk of breast cancer. I would have only thought between P53 and KRAS. Answer is KRAS. KRAS is related to colorectal cancers. Okay, KRAS is related to colorectal cancers, some pancreatic cancers. P53 can have all cancers. BRCA1 and BRCA2, of course, they have a higher lifetime risk of breast cancer. Now, I am giving you an update, daily update. It's there on my Instagram also. For BRCA1, okay, for BRCA1, which means if I got the BRCA1 mutation, it is proven by gene testing. Maybe my mother had it and I got it. If I have BRCA1, my lifetime risk of breast cancer is very high. It is to the tune of 50 to 85%. And my lifetime risk of ovarian cancer is 40%. Okay, if I have BRCA2 mutation, then my lifetime risk of breast cancer, please note these points, new updates, daily updates. Lifetime risk for breast cancer is 50 to 60%. This is not there in the old Bailey. This is there in 20th edition only. And lifetime risk of ovarian cancer is 25%. Okay, I'll give you a trick to remember, easy trick to remember. For BRCA1, remember 80-40. 80% breast, 40% ovary. For BRCA2, remember 50-25. 50% breast, 25% ovary. Okay, this is how I would remember. This is how I remembered it for today. And your exams are close enough, now you should be able to remember this. Lifetime risk, which means if I have BRCA1 or BRCA2 mutation, this is the chance of me getting breast cancer in my lifetime. It's very high. Okay, which is why one of the actresses underwent prophylactic mastectomy, because she had BRCA1 mutation and she knew breast cancer risk is 80%, so she underwent prophylactic mastectomy. Okay, before we go, yeah, we got this. Okay, expected. This is what I will put. If I put a question, I will put this, expected. Similar question came in INI CET last year. Similar, I have changed it and I have put the solution is a direct copy paste from Bailey. Okay, I have put a copy paste from Bailey for the solution. Okay, so whatever comes in the next slide is word to word from Bailey. 20th edition. It was not there in the old edition. Which of these is not a contraindication for breast conservation therapy? Diffuse microcalcifications, history of previous chest radiation, palpable axillary nodes, or SLE. Let's see what you think. It's an interesting one. It tests your thinking, your concepts. It tests how much you have understood these kind of topics. And that's why they keep asking these kind of topics, because they know they will catch you off guard in the fundamentals of these topics. But after today, these topics will be piece of cake. See, I'm getting B, C, and D. Okay, I'm getting B, C, and D. Prachi, I never said absolute or relative, right? I just said not a contraindication. Which of these is not a contraindication? Which means the options are beautiful, because B, C, D are all being marked. Okay, before you come to the answer, what does BCT mean? What am I doing in BCT? BCT means I'm going to do wide local accession. And for lymph nodes, I will do either sentinel lymph node biopsy, or I will do axillary lymphadenectomy. Means remove the axillary nodes, and I am going to give radiation. This is the meaning of BCT. I have taught most of you here know this from me from before, because you have been my students in the past. So when I say BCT, I have to do surgery. So I remove the tumor with 1 centimeter margin. For lymph nodes, I decide based on SLNB, or if the nodes are present, I straight away do axillary clearance. And I do radiation. So for me to say a contraindication, it means it has to be a contraindication to radiation, or a contraindication to wide local accession, or a contraindication to axillary dissection. One of these three, if it's contraindicated, I cannot do BCT, because all the three components have to be done. If there are diffuse microcalcifications, that means the tumor has multiple parts in the breast, which means I cannot do a wide accession of each component. How much percentage of breast can I remove in wide local accession? Approximately, new update of Bailey. There are a lot of breast surgeons you may have learned from them. How much percentage of breast can I remove without requiring to do any reconstruction in wide local accession? Okay, anyways. So diffuse microcalcification, I cannot do wide local accession. Previous chest radiation, if it is there, giving chest radiation again is a problem. Cross margin is 1 centimeter. Cross margin, visible margin 1 centimeter. Microscopic margin 1 millimeter. If the person has SLE, it is contraindicated for radiation. So connective tissue disorders, you will have to avoid giving radiation. So the answer is palpable axillary nodes. The thinking is there that if the nodes are palpable, I will straight away remove the axillary nodes. I don't have to do SLNB, but I will do axillary clearance. Why is this a contraindication? If a person has a 2 centimeter tumor with single ipsilateral axillary node, which is mobile, this becomes T1N1. Can I not do BCT in him? Of course I can do. So why is this a contraindication? Palpable axillary node is not a contraindication. Fixed axillary node is a contraindication, because I cannot remove the axillary nodes. So be very clear. Now I will tell you what is given in Bailey. This is a direct line. Don't worry about the whole list that they have given. You have to see the key points. Okay, because the question will come from this. This is from the 20th edition. This exact I have done copy paste. What is the key point? Key point is multicentric tumor, diffuse, very large tumor, can't do WLE. Wide local accession can't be done. Okay, 2 times positive, no more breast is left for wide local accession. These are all contraindications to radiotherapy. Even severe orthopnea, because you cannot give radiation because you cannot lie down. These are all contraindications. Okay, they are relative. Some of them are absolute, some of them are relative, but these are the contraindications. It's there clearly in Bailey. The fundamental is, if I cannot do any of these components, I cannot do BCT. Don't mug up the contraindications. The last question, how much quantity of breast can I remove in wide local accession without having to do some reconstruction? Yeah, how much quantity of breast can I remove? How much? How much is too much? I will give you options. I can remove 10%, 20%, 30%, or 40%. How much breast can I remove? Ankylosing spondylitis, collagen vascular disorder, immunological disorder will aggravate if you give radiation. Answer is 20%. Up to 20%, I don't need to do any oncoplasty. Okay, 20% tak oncoplasty is not required. If it's more than 20%, I would have to do some kind of a reconstruction. It's not my answer. It's there in Bailey. Okay. Now moving on, another important concept, very, very important, VVIMP. VVIMP. What is this visualization called? This is again new Bailey. The image is also there in Bailey. Similar image. This is from Bailey, 20th edition. What is this visualization in lab cholecystectomy called? On my Telegram, I posted a question about this, and 40% people answered something else. 40% people answered lap inguinal hernia. I posted this question on my Telegram. Yeah, excellent. This is critical view of safety. Okay, this is critical view of safety. What is critical view of safety? And on my Telegram, when I posted critical view of safety is visualized in 40% people marked lap inguinal hernia. 25% people mark cholecystectomy. Other people mark crystalline ano. I don't know why. Yeah, what is critical view of safety? Just out of curiosity, what do you see, or why are you calling it critical view? Critical view of safety means I should be able to see the cystic duct and the cystic artery entering the gallbladder. I should see them entering the gallbladder, which means this medial structure is the cystic artery. You can see it is entering the gallbladder. This lateral structure is the cystic duct entering the gallbladder. This is the gallbladder. And I should see liver in background. In the background, I should be able to see the liver in between. So I should be able to see, you can see in between all this brown thing that you see over here, over here, over here. All this in the background is the liver. This is called critical view of safety. All right, this is called critical view of safety. Till I don't visualize this, I cannot proceed with cholecystectomy. So when I dissect this area of Callet's triangle, I have to separate these structures. This is critical view of safety. I go one step ahead. This is also given in Bailey. What is this structure called? This groove over here. They will ask you this in an IBQ, image based. They will ask you this. This is also given in Bailey. What is this structure that you see over here? You know, this is the gallbladder, and this is the liver, and there is something over here. It is seen in most of the patients. I think Tanmay Murur is Akanksha Nag. I don't think Tanmay Murur is Tanmay Murur. People who are already given entrances should not be answering, so that we don't occlude it. We don't occlude what? Yeah, this structure have a very, very good appearance of it. This is called Rouvier's sulcus. Okay, this is called Rouvier's sulcus. Rouvier's sulcus contains the right branch of hepatic duct, the right posterior branch of hepatic duct. The fundamental about this is, whenever I'm doing Callet's triangle dissection, my dissection line should be above the Rouvier's sulcus. So all my dissection should be above this line, above the line of the Rouvier's sulcus. This line passing through the Rouvier's sulcus, it has a name. Anybody knows the name of the line? Also there in Bailey. What is the name of this line? Which passes through the Rouvier's sulcus, passes through the fourth segment. Yeah, it passes through the fourth segment of the liver. What is the name of this line? Think about it. The more I ask you to think, the more you start wondering and not thinking. Yeah. So while you are thinking of the name of this line which passes through Rouvier's sulcus and the fourth segment, Indications for cholecystectomy in a patient with asymptomatic gallstones. Asymptomatic means you did an ultrasound, he has gallstones. Normally, you don't do cholecystectomy if he is asymptomatic. So when will you do cholecystectomy for asymptomatic gallstones? This is also going to come as an MCQ. They will say all of these are indications for cholecystectomy in asymptomatic gallstones, except. So asymptomatic gallstones and cholecystectomy you are going to do in if the person has stones with polyps. So if he has a GV polyp and he has stones, or if he has a hemolytic anemia, hereditary spherocytosis, or if you are planning a bariatric surgery. As a part of bariatric surgery, if he has gallstones, even though it's incidental, asymptomatic, you are going to do cholecystectomy. Otherwise, asymptomatic gallstones, no need to do cholecystectomy. Unless he gets some complications or any of these findings are there. Yeah, what is the name of this line? It passes through Ruvier sulcus. It passes through the fourth segment. It passes through something called umbilical fissure. This is called R4U line. Okay, R4U line. Porcelain gallbladder you can remove even if there are no gallstones. Okay, because it's pre-malignant, so you don't need stones for that. Stones more than 3 centimeters. Okay. In the image, this balloon that you see, what is it inflated with? I hope you can identify what this balloon is. Very nice. Surgery के नाम मत याद रखो, पर ये याद रखना पड़ेगा R4U line, because the problem is, you know what? Every surgeon who is going to set your paper is going to know everything about hernia, is going to know everything about cholecystectomy, because all the surgeons do hernias and cholecystectomies. They may not know urethral trauma, but they will know cholecystectomy. So first you need to identify what this tube is, what is this part of the tube, what is this part of the tube, and the part that I have marked, what are you going to inflate it with? Yeah, A, B, C, D, A, D. Okay, what is this? What is the name of this tube? This is Sengstaken-Blakemore tube or SP tube. Okay, this is SP tube or Sengstaken-Blakemore tube. It is used for balloon tamponade in variceal bleed. It is used for balloon tamponade in variceal bleed. Now, please understand, though this looks very small, don't get confused. Is it gastric or esophageal? Okay, Prakriti has gone for 30 cc air. This is the distal part of the tube. So the first balloon is going to be the gastric balloon. So this is the gastric balloon. This is the esophageal balloon. Even though it looks big, it is actually small because it will only fill the esophagus. Lightweight air pool. Okay. So this is the esophageal balloon. Now let me tell you what Bailey has said, which is a little controversial, but we will go with what Bailey says. We are not going to go with what facts say. A, B, C, D, सारे answer मिल गए. Wonderful. This is a perfect question I have asked. Now let me tell you what Bailey says. What Bailey says is, when I am going to put the SP tube, okay, when I put the tube, I will first inflate the gastric balloon. Okay, first I inflate the gastric balloon. Obviously, it will fill the fundus of the stomach, and that is going to be a very big space. So gastric balloon has to be filled more, and that is going to be 300 cc. Of what? I will tell you. Then I pull the tube up. Now when I pull the tube up, it will come here, and I pull it so that it compresses the varices, and most of the times that will stop the bleed. Bleed will stop after I pull the tube up in most cases. So gastric balloon is going to be 300 cc of something. If the bleeding persists, then I will inflate the esophageal balloon. Only if the bleeding persists. And esophagus is a small space. I am not going to fill in 300 cc. There is no space. The esophageal balloon is going to be 30 cc. of what I will tell you. Now what Bailey says for both, unfortunately, what Bailey says for both is air. So we will go with air. Okay. Bailey says air, we will mark air. If Bailey said air, water, we would have marked it, but unfortunately, this is what he says. It's not very correct, but we will go for air. So gastric balloon, this is gastric balloon. Answer is going to be 300 cc air. Okay. In real world, it should be saline, but forget about it. Don't go by real world. Don't go by what real world says. Go by what Bailey says. Gastric balloon, 300 cc air. Esophageal balloon, 30 cc air. The actual values are a little different. There is some range, but I want to make your life easy. I don't want you to do Pritara Ratna. I will make it simple. 300 cc, 30 cc. 1/10. Okay. 300 cc, 30 cc. Met turtle, you can ask me on Telegram. It's why it's actually not correct. There is a reason for it, but I don't want to add more ambiguity at this stage. You can ask me personally, no problem. This balloon, interesting image. This has gastric balloon port, esophageal aspiration port, esophageal balloon port, gastric aspiration port. So there are 4 ports. This is the Minnesota tube. Okay. 4 lumen is the Minnesota tube. 300 cc air कैसे डालेंगे? डाल सकते हैं यार, 50 cc syringe से डाल सकते हैं. This is the Minnesota tube. It has 4 lumen. I have put this image for the simple reason that Minnesota tube and SB tube, they look very similar. Okay, they look very similar. Just look at the ports. Don't jump the gun on it. Look at the ports. How many ports do you see? You see 3 ports, SB tube. You see 4 ports, 4 channels, Minnesota tube. All right, that is about important concept of SB tube in variceal bleed control. Variceal bleed, again a topic you should know the full pathway of management. This is NEET 2020. I am sure you have learned this well from your favorite teachers. I will teach it to you my way. If you wish, you can take my way or you can stick to the way that you know. So how do you calculate child score? This is NEET 2020 question. They should not be asking such scores, but they do. If they do, you can't help it. You have to know it. I will tell you how to calculate it my way. Okay, easy way, which will require a minimum ratna, minimum mugging. Few things you have to mug, very few. All right, I will tell you how I would do it. Now, first things first, the points are going to be 1, 2, 3. Okay, 1 being the best, 2 being middle, 3 being the worst. And the components are, how I would remember it, how you would have also learned from some other people, is A, B, C, D, E. I'm sure. Because a child learns ABCD first. So child score should be ABCDE. I'll tell you my way of remembering it. A is albumin. B is bilirubin. C is not creatinine. Okay, C is not creatinine. C is coagulopathy or INR. All right, C is coagulopathy or INR. D is distension or ascites. And E is encephalopathy. Okay, now first you need to know in one what are the normal values. Normal albumin should be more than 3.5. Normal bilirubin should be less than 2 mg%. Normal INR should be less than 1.6. These are normal values. You would be knowing these values. Distension should be absent. Encephalopathy should be absent. Now comes the critical part, the values. What is 2? What is 3? So this is the part that you need to mug a little. And I'll tell you how I have simplified it. You can choose your own ways. For albumin, remember the factor 0.7. For bilirubin, remember the factor 1. For INR, again, it is 0.7. Plus, that's all you need. 0.7, 1.7. That's it. Then it's easy to calculate 2 and 3. Now, 0.2 will be, if it is 3.5, and you subtract 0.7, which means it will be 2.8 to 3.5, and 3 will be less than 2.8. So I just subtracted 7. Bilirubin, it has to get worse. So 2 is going to be 2 to 3. The factor is 1. 2 plus 1, 3, and more than 3. For INR, best is 1.6. You add 0.7. So this is going to be 1.6 to 2.3. This is going to be more than 2.3. Okay, easy enough. The mugging part is only this. If there is some better way of remembering it, please go by that. This is how I would remember it. Distension should be mild. This is 2. And this should be refractory. That is 3. Again, this should be mild. And this should be refractory. Now it becomes easy. Bilirubin is 2.5. So he gets 2 points for this. Albumin is 3. He gets 2 points for this. INR is 2. He gets 2 points for this. Mild ascites is going to be 2. No encephalopathy is going to be 1. Total score is going to be 9. 7 to 9 is going to be B. Okay, so B is going to be 7 to 9. A is going to be 5 or 6. And C is going to be 10 or more, 10 to 15. There is no child D, luckily. All right, easy way to remember. This requires very minimal mugging. The only mugging part is this 0.7, 1.7. The rest you can automatically conclude by using these factors. Right? Before you understand or before you mug all this, what is the purpose of child score? Why am I doing child score? What is child score telling me? What is the difference between child A, child B, child C? What is the purpose of child score? Whenever my student studies any score, classification, system, staging, you should ask this question. What is the score telling me? Is it telling me severity? Is it telling me diagnosis? Is it telling me prognosis? What is it telling? Because all scores have a reason. Like I told you for retroperitoneal hematoma, zone 1, zone 2, zone 3. Zone 1 is the biggest injury possible. Zone 2 is something in between. Zone 3 is the least. It's not telling me liver transplant. No, it's not. It is telling me severity of chronic liver disease. Okay, it is telling me severity of chronic liver disease, which means this will apply to someone who has a chronic liver disease or cirrhosis, which means you and I should not have our own child score. We are not child A. Okay, we are not child A. Our child A, if we calculate, will be 5, but we are not child A. The score does not apply to us. The score applies to someone who has chronic liver disease. Means he should have cirrhosis. It tells me severity of cirrhosis. Where child A is least severe, moderate severe, very severe. Which is why child C is someone who should get a liver transplant. Child A and some child B, you don't need because it's not severe enough. Just an offshoot. What is Milan criteria? Just an offshoot over here. Milan criteria. You will study this in liver tumors. What is Milan criteria? What is this criteria telling? Is it telling me severity of anything? Or is it just some fun criteria? MELD score is again, it tells me suitability for liver transplant. That is MELD score, end-stage liver disease. I am asking you, what is Milan criteria? When you study scores like this and you ask this question, then only you'll remember the principle behind it. And then only you'll remember and not get confused. Milan criteria is not for liver transplant. Absolutely not. Liver transplant CMS, HCC, okay. It's not a liver transplant criteria, nor is it an outcome criteria. No, it is a criteria for suitability. So partly correct, it is a criteria for suitability of liver transplant in a patient who has cirrhosis and HCC. Cirrhosis and HCC. When you get the word criteria, criteria means if I fall in this criteria, I get some benefit. If I'm out of the criteria, I don't apply. So the criteria tells me in a patient with cirrhosis and HCC, if he fills in the criteria, he will get a liver transplant. So it is a suitability of liver transplant, but not in anybody, in a patient who has cirrhosis and HCC. And you know what the criteria is: single tumor, up to 5 centimeters, or maximum 3 tumors, each less than 3 centimeters. If this is seen in a patient with cirrhosis and HCC, he can get a liver transplant. This is what it means. It's a suitability criteria for cirrhosis and HCC together for liver transplant. MELD score is only liver transplant, whatever is the etiology, whether it is cirrhosis, hepatoma, Hep B, Hep C, it doesn't matter. MELD is a blanket score. Milan is cirrhosis with HCC. Okay. Now you'll remember this if it comes in your exam. No confusion. Okay. This is what I already told you. This is the kind of topic which really bothers students. You know, a lot of my students ask me investigations, diagnosis in patients with hepatobiliary pathologies. Let me make it simple for you today. So hepatobiliary pathologies, how to simplify? Yeah, how to simplify. So patient presented, he is an alcoholic, smoker, waxing and waning of jaundice, CT showing dilated CBD, pancreatic duct, most probable diagnosis. You know, this came in INI CET last year, and even on a topic like this, students were confused, which is surprising because there is nothing confusing in this. What is this appearance called? CT shows dilation of CBD and pancreatic duct. What is it called? This dilation. So what the image is saying is, on CT, I saw CBD is dilated and pancreatic duct is dilated. So I saw dilation of both the ducts. What is this appearance called on CT? This is called double duct sign. Double duct sign, it's a finding of periampullary carcinoma. All right, it's a finding of periampullary carcinoma. Now, I am simply trying to tell you, how are you going to investigate a patient with obstructive jaundice, or basically a patient with jaundice of surgical origin or obstructive jaundice? Please understand, whenever there is a patient who comes with obstructive jaundice and they ask you first investigation, you are going to do liver function test and then you are going to do ultrasound abdomen. So your diagnosis first step is going to be LFT ultrasound abdomen. Ultrasound abdomen will tell me, is it a biliary block? Is it a CBD block? Is it CHD block? It will tell me the site of the block. So first investigation is always going to be ultrasound abdomen. So if they give you a question, they will give you the scenario, they will give you USG findings. You have to decide what next. Now, what next depends on what I saw on ultrasound. Okay, what I saw on ultrasound. If the ultrasound said that the person has CBD stones and they ask you next step, what will your answer be? If the ultrasound said there is a distal CBD block, then what are you going to do? And if the ultrasound said there is a proximal CHD block, what will you do? So in each scenario, based on ultrasound, you have to give your diagnosis. Distal CBD block means it will look like this. This is how distal CBD block will look. So that everything will be dilated, gallbladder will be distended, and the block will be somewhere over here. This is distal CBD block, somewhere here. Proximal CBD block will be like this. This will be dilated. Somewhere here is the block. Everything else is collapsed. Gallbladder is collapsed. This is proximal CBD block or CHD block over here, somewhere over here. And the third is CBD stones. And they ask you next step. Absolutely, there should be no doubt about these things. If they ask you CBD stones, if you have seen CBD stones on ultrasound, ultrasound said yes, CBD stone, single stone, 2 stones, 3 stones. Next step is going to be ERCP. So absolutely clear, ERCP is when I know the diagnosis. When I know the diagnosis, I will do ERCP. Please, ERCP will never be done to diagnose. It will be done to treat, not to diagnose. So if I know there are CBD stones, I will do ERCP. If there is a distal CBD block, what is the next step? Next step or next investigation, distal CBD block, and next investigation for a proximal CBD block. And they love asking this in INI CET, and students always make a mistake. So they keep repeating these topics because they know that you have mugged the damn concepts and you have mugged the answers. So how much can you remember? You'll remember mugging in surgery or medicine or anesthesia or psychiatry, how much? If there is a distal CBD block, like you are suspecting a periampullary carcinoma, if you are suspecting a periampullary carcinoma, no, you are going to do CCT abdomen. Okay, you are going to do CCT abdomen. It is the investigation of choice for CA pancreas, CA gallbladder, and CA liver. It is the investigation of choice. All right, CA pancreas, CAGB, and carcinoma liver. The only tumor where CCT is not the investigation of choice in the whole of hepatobiliary tree, the only tumor where I don't prefer CCT is a tumor over here. That is Klatskin tumor. For Klatskin tumor, I will prefer MRCP. All right, I will prefer MRCP. If CCT is not there in the option, then the next answer will be MRCP or EUS. All of them are fine. But the fundamental is for proximal blocks, MRCP is the best. So MRCP is the investigation of choice for Klatskin tumor. And CCT is the investigation of choice for pancreas, GB, or liver. Okay, be very clear about this. And most of the times, the students prefer to mark ERCP. ERCP is what will kill you, because understand, ERCP causes pancreatitis in up to 3% population. Every ERCP that I do, there is a 3% risk of pancreatitis. So please don't do ERCP unless you know the diagnosis. If I ask you indications for ERCP in general surgery, in the whole of general surgery, the answer is when I know that there are CBD stones. How I know? Either on ultrasound or on MRCP, or when I know there is a bile duct injury, bile leak after cholecystectomy. When I know there is a bile duct injury. So these are the scenarios where I'll do ERCP. And the last, there is only one diagnosis which is done by ERCP. It's actually not even ERCP. There is only one scenario where ERCP is used for diagnosis. Anybody can answer. Only one disease in general surgery where ERCP will give me diagnosis. CCT can be done, but better than CCT is MRCP for proximal blocks. It picks up better than CCT. Because Klatskin is cholangiocarcinoma, it will grow into the lumen. Where do I use ERCP for diagnosis? Only one disease in general surgery for diagnosis. No, not biopsy. For biopsy, I don't need ERCP. Okay, think about it. Patient presents with fever, jaundice, upper abdominal pain. USG revealed a stone in CBD, dilated bile duct, and biliary radicals. Next, appropriate step in management. This is a question that was asked. For IPMN, I don't need ERCP. For IPMN, I just need a side viewing endoscopy. Excellent. Neha has given the answer there. Brilliant answer. Only one disease, that is sphincter of OD dysfunction. Okay, only in this disease will you do ERCP for diagnosis, sphincter of OD dysfunction. It is actually ERCP with manometry. All right, ERCP with manometry. Otherwise, you are not going to do ERCP for diagnosis. You do ERCP for diagnosis, patient gets pancreatitis and dies, you will go to court. Life is over if he gets pancreatitis and dies. Anyway, USG revealed a stone. If I see a stone, answer is ERCP. If I am suspecting CBD stone, then please don't mark ERCP. Okay, if I am suspecting CBD stone, then the answer will be MRCP. Okay, I will put it in a nutshell. This is a little confusing, but this is from Bailey in a very simplified nutshell. Investigation of choice for gallstones is going to be USG abdomen. Investigation of choice for CBD stones diagnosis is going to be MRCP. MRCP is better than CCT. And investigation of choice for small biliary calculi, I don't expect them to ask this. It's a ridiculous question. I don't expect this to come, but this was there in Bailey 27th edition. 20th edition, they have removed this. This was there in Bailey 27th edition. For small biliary calculi, answer is EUS. Okay, so these are the two slides. Please keep them well ingrained in your system on next step. Okay, or investigation of choice. I have no doubt about any of these. First slide is this one. If I know there are CVD stones, ERCP. Distal CVD block where I'm suspecting a tumor, it will be CECT, where I'm suspecting a tumor. Proximal, MRCP. As simple as that. And this is the other one. Investigation of choice for CVD stones, MRCP, small biliary calculi, EOS, all stones, USG apple. Yeah, if you add gold standard and everything, your life will become a mess. Don't go for gold standards. Nobody does HIDA scan. Okay, nobody does. So don't bring in more factors and more permutations. This is actually what is done. This is actually what you should know. This is the core of general surgery in hepatobiliary. Okay, this is what you are actually going to do. HIDA scan, nobody really does. Okay, this is expected. If I set your paper, I will put this question. I would put this question because it covers medicine, surgery, dermatology, 4-5 things. Physiology, pathology, a lot of things come in this image. Female presents who is recently diagnosed diabetic with this rash and she is depressed. What will you advise her for this? Yeah, what are you going to advise her for this? Recently diagnosed diabetic. She has this funny looking rash. Even if you don't know, for biliary leak, ultrasound followed by ERCP. Ultrasound will show there is a biliary leak. There is a collection after cholecystectomy. To diagnose and treat, I will do ERCP. What is this appearance? What is this funny looking thing over here? Yeah, I'm happy many of you know this. Friends forever DDD. Okay. This is fasting glucagon. What you see here, this is called necrolytic erythema migrans. Necrolytic erythema migrans. This is seen in glucagonoma. What are the 4 Ds of glucagonoma and which D is missing? What are the 4 Ds of glucagonoma and which D is missing? So it's a rule of 4 Ds. One is what I already told you, dermatitis. The second D is what she had, depression. The third D is diabetes, because glucagonoma will lead to hyperglycemia. What is the 4th D? And which D is missing, which is seen in other endocrine tumors, but rarely seen in glucagonoma. What is the 4th D? No, it's not dementia, it's depression. What is the 4th D? Death. Don't kill the patient. And which is the missing D? The 4th D is DVT. And the missing D, which is rarely seen, which is rare, that is diarrhea. So your MCQ is going to be, patient will be having some features of glucagonoma and they will give you which of these is not a component. Options will be depression, diabetes, DVT and diarrhea. Answer is diarrhea. Most of you will mark DVT. Okay, most of you will mark DVT, but answer is diarrhea. Okay, diarrhea is rare. It can be seen, but amongst the others, it's very rare. All other endocrine tumors, gastronoma, VIPoma, they have diarrhea as the prominent feature. Okay, diarrhea commonly seen, gastronoma and VIPoma. VIPoma is also called pancreatic cholera. Insulinoma is alag. Whipple's triad. Acha, what is the investigation of choice for glucagonoma? How do you diagnose it? Investigation of choice. Yeah, I will touch on hernia. I think I will go on for another half an hour to 45 minutes. What is the investigation of choice for glucagonoma? Also for gastronoma, VIPoma, non-functional pancreatic tumors, barring insulinoma. Investigation of choice, SRS. Okay, SRS, somatostatin receptor scintigraphy. This works for all endocrine tumors of pancreas. All endocrine tumors of pancreas show positivity for SRS except insulinoma. Okay, except insulinoma. Octreotide scan is a type of SRS only. Somatostatin and octreotide are the same. Okay, so all except insulinoma, you will do SRS. For insulinoma, it does not have somatostatin receptors. In that case, you can do CT or MRCP or EUS. Okay, again, important topic, endocrine tumors of pancreas. Now, a few easy topics. This is the image. What is the image? First, just tell me the image, means the technique. And what is the treatment? Patient presents. This is the image given. Please tell me what is the image first, not the diagnosis, the image. Is it a X-ray abdomen, X-ray KUB, IVU, retrograde urethrogram, retrograde pyelogram? What is this image? Nishant is saying IVP. And what's your diagnosis? Buddhapriya is saying IVP, backpack. One person says IVP, everybody is following IVP. Yeah. Yeah. Prakriti, Neha Chogale, Tanmay Murur, aka Akanksha Nag. What is this image? This is IVP with staghorn calculus. If this is IVP, where is the kidney shadow? Where is the ureter shadow? Where is the bladder shadow? It's not an IVP. Okay, this is not an IVP. This is a plain X-ray KUB. Okay, disaster. This is a plain X-ray KUB. Please understand, in an IVU, you are going to see contrast in the bladder. You may see contrast in the ureter, depending on what phase it is, or at least you should see nephrogram. Here you are seeing neither. Here you are seeing nothing. It's not a retrograde pyelogram. This is a plain X-ray KUB. Unless you see contrast in the bladder or in the ureter, it is not an IVU. Now, what is it showing you? It is showing you these nice big radio opacities here, and this is little less radio opaque. So this is staghorn calculus. The question is, patient presents with colicky pain. This is the X-ray image. What is the treatment? Options are going to be medical expulsive therapy. That is A. Option B is going to be ESWL. Option C is going to be PCNL. Option D is going to be RIRS. And option E is going to be surgery. Okay, option E is going to be surgery. What is the treatment? Yeah. Come on, quickly. A, B, C, D, E. You are giving ESWL with PCNL. Usually you don't need to do both. Usually one works. And even if I say ESWL with PCNL, you have to pick one answer. So the best answer is going to be PCNL. Okay, best answer is going to be PCNL. Now, there are some things which have changed in the new Bailey. Some things which are changed. Okay. When do I do ESWL? When do I do just expulsive therapy? And when do I do these other fancy things? Expulsive therapy is only going to be done for stones less than 5 millimeters. Okay, 5 millimeter or more, stone is unlikely to pass. So first be clear, expulsive therapy, stone less than 5 millimeters. ERCP, stone between 5 millimeters to 2 centimeters. Okay, some places it's given 1.5 centimeters. 1.5 to 2 centimeters, this is the bracket, you can do ESWL. But mind you, I can do this only if it is non-lower calacial. It should be non-lower calacial stone and it should be a soft stone. Okay, it should be non-lower calacial and it should be a soft stone. Only then I can do ESWL. Anything beyond this, I have to choose one of these. Now we have always learned PCNL. I want you to know about RIRS because this is there in New Bailey. So I have put it from Bailey, indications for RIRS. Just remember RIRS. RIRS is ESWL contraindication. So wherever ESWL is contraindicated, but stone is small, I will do RIRS. This is from Bailey. So lower calacial stone anatomical problems, stone in horseshoe kidney, bleeding disorders. In these scenarios, I can't do ESWL. Even though the stone is small, I will do RIRS. Okay, RIRS is a type of endoscopy for renal stones, retrograde intrarenal surgery. This is given in Bailey, and it's a very popular procedure. So this is the new thing. It was not there before. New thing, it is there in Bailey. It was not there in the older edition. In the older edition, RIRS was not even mentioned. So up to 2 centimeter stone, but I can't do ESWL. I will do RIRS. Okay, RIRS is retrograde intrarenal surgery. Okay, retrograde intrarenal surgery. It's a type of endoscopy. Endoscopic management of upper ureteric or renal stones. And the last thing, when do I do PCNL? PCNL is done for stones more than 2 centimeters, stones which are very hard, and any scenario which is abnormal. Anything abnormal, go for PCNL, because PCNL is a surgery. So if they give you anything complicated like staghorn stone, answer is going to be PCNL. So my message to you is, small stones, you will choose between ESWN and RIRS. Big stones or complicated stones. Stone in someone who is very obese. Stone in someone who has a bleeding problem. Stone in someone who is abnormal anatomy, where other procedures have failed. You will do PCNL. PCNL will work where nothing else works. Okay, just to put it in simple words. So anything complicated, multiple stones, impacted stones, very hard stones, failed ESWL, failed RIRS, answer is PCNL. Okay, very simple. This is a wonderful question. It came in NEET PG last year. It's a beautiful question. It actually tested the thinking of students. Whenever I teach oncosurgery, my students love oncosurgery and trauma the most. It's because oncosurgery, though it's so complicated, for solving MCQs, you need to know a few principles. Stage treatment, stage treatment, stage treatment. That's how we are going to do. So, how are you going to treat a patient who is 85-year-old with carcinoma prostate, with a Gleason of something, tumor something, PSA something? Brachytherapy, external beam, surveillance, radical prostatectomy. It's a repeat question, but it is testing the concepts, beautiful concepts. And I will make it simple. I will change some permutations also for you. Most of you are saying active surveillance. Why is that? Okay, answer is right. Active surveillance is right. If the patient was 65 years old, would your answer change if he's 65 years old? Then does it make a difference? Means what has made you go for surveillance? And I will put it in a very simple chart. How are you going to treat CA prostate based on the factors, based on the stage? Stage-wise treat, very simple. Age. So now I made it 65. Okay. Age more, so no radical surgery. Okay, let's say I keep his age at 85 and I make his PSA as 28. Doesn't matter. You are stereotyping. Just because his age is 85, you are stereotyping that let's not do anything. Okay, have a good look at this. I will make your life very easy in oncosurgery. You don't need to remember the exact T&M stage. You just need to remember the principles. That in CA prostate, T1 and T2 tumors are the only tumors which are operable. Okay, these are the only tumors which are operable. T3 and T4 tumors are going to be inoperable. So first get this clear. They are going to be inoperable. All right, first make this boundary. Which patients can be treated by surgery, which patients cannot. Operable means for these tumors, the preferred treatment would always be radical prostatectomy. And for these tumors, since they are inoperable, it's going to be androgen ablation. For both these scenarios, androgen ablation. So T1, T2 tumors, radical prostatectomy. T3, T4 tumors, androgen ablation. First, get this ingrained in your system. T1, T2 are the only tumors where you can do surgery. Nowhere else. T3, T4, some T3 you may be able to do, some early T3. Now the question comes, does every patient with a T1, T2 tumor warrant a radical prostatectomy? Because they found that carcinoma prostate takes a very long time to cause metastasis. So they realized, since most of these patients are senior citizens, 70, 80 years old, and their life expectancy is maybe another 5 to 10 years, do they need a radical prostatectomy? They found if you can keep them on surveillance, it's okay. They don't need a surgery if they fulfill some criteria. So you can do surveillance for early tumors if they fulfill some criteria. The question is testing this criteria. That's it. If these 4 criteria are there, you can do surveillance. Otherwise, you go for radical prostatectomy. This is the fundamental of this topic. Please understand this. This is the funda. That beyond a point of time, you will not do surgery, you will do ablation. Before this, where you can operate, other alternative surveillance. Now, surveillance, this you need to know by fact, age more than 70 years. Some T1 tumors, and they should have low tumor burden. PSA should be less than 10 and Gleason should be 6. Okay. Currently, there is nothing like Gleason's 5432. Now Gleason is 6, 7, 8, 9, 10 only. Anything below 6 is counted as 6. Okay, this is there in Bailey. Anything below 6 Gleason is counted as 6 because they said whether it's Gleason 5 or 4, outcome is the same. So, if these criteria are fulfilled, you can do surveillance. So mainly it is for these kind of tumors because they felt risk of becoming metastatic will take a long time. So by the time he gets lumbar vertebral mets, lung mets, it may be very late. So no need to do radical prostatectomy in these patients. Okay. Important image. Image is not important. What I will tell you next is more important. What is this beautiful looking image? This was asked in INI CET, I think. Few months back, last INI CET. Yeah. What is this image? Easy peasy. Yeah, this is a bladder exstrophy or ectopia vesicae. Okay, ectopia vesicae. How do you differentiate all of these? This also looks like intestine even though it is not. If you get any confusion, whether it's ectopia vesicae, gastroschisis or omphalocele, they will always show you the umbilicus or the umbilical tube. If the problem is infraumbilical, if you see a lot of things happening in the lower abdominal wall, infraumbilical, it is extrophy bladder. Anything which is around the umbilicus will be one of these because actually they are types of umbilical hernias. They are variations of umbilical hernias. So gastroschisis, omphalocele, I'll show you how they look. Look very different, but they still are confusing. They are going to be around the umbilicus. Okay. Extrophy bladder is going to be infraumbilical. It's lower abdominal wall defect. Now it looks like this. This is gastroschisis. There is no membrane. Okay, it's just free lying intestines. There is no membrane, no covering. And in omphalocele, there is a membrane. This is omphalocele. It is covered by peritoneum. Right? Please understand, gastroschisis is seen in young mothers. Okay, it is seen in young mothers. Young mothers means mothers who have children below the age of 20 years. And it has very few other abnormalities. It is an isolation. It's not a syndromic problem. It's an isolated problem. It's an abdominal wall problem. This is what I want you to remember. How are you going to repair ectopia vesicae? This is in the old Bailey. It was not given so well. This is there in new Bailey. New update. How are you going to repair the different components of ectopia vesicae? Because understand, in ectopia vesicae, there are 3 problems. One is abdominal wall and bladder. So abdominal wall is missing. Bladder is missing. Some parts of the bladder. Second problem is problem in the penis. Epispadiasis in the penis. There may be a chordee of the penis. And the third is there is a weakness in the bladder neck. So there is bladder neck weakness. Yeah, hernia topic I will reach there, don't worry. Everybody wants to learn hernia. Hernia is important, no doubt. We will get there. So these are the three problems. There is a problem in the abdominal wall. It is weak, it is missing. Sometimes bladder is missing. There is a chordee of penis, there is epispadiasis, and there is bladder neck weakness. The sphincters are not developed. So he is incontinent. How am I going to repair this? This is given in Bailey, staged repair. It goes like this. In the neonatal period, you will repair the abdominal wall. Okay. If they want to screw you on a topic like this, they will ask you in what period. They love asking timelines. They will ask you this timeline. So abdominal wall repair in neonate, typically in 4 to 6 weeks. Penis is going to be repaired typically at 4 to 6 months. And bladder neck is going to be repaired at 4 to 6 years. Okay, this is just my way of remembering it. Exact values are a little different, but this is how the period of repair is going to be. You don't repair all at once, you will repair it in these stages. This is as per Bailey, 28th edition update. Okay, in the old Bailey, they had not given so many phases. Now you need to know these phases of repair. And now it's very close to your exam. So now I think you will be able to remember it also till your exam. It's not going to be that difficult. So first you will repair the abdominal wall, the bladder wall. Then you will repair the penis, the epispadiasis. Last you will repair the bladder neck. Okay. Few questions on plastic surgery. If I set your paper, I would put this. According to Wallace's rule, what does genitalia represent? What percentage of total burn surface area is genitalia? Is genitalia going to represent? Hypospadiasis? No, there is no hypospadiasis here. There is epispadiasis. According to Wallace's rule, genitalia represent what percent of burns? Total burn surface area. Wallace's rule as such is not a very accurate rule, but they love asking it. 0.5, 1, 2 or 9%. Okay, genitalia, yes, it is 1%. Excellent. Now, what the rule says is, it's a rule of 9. But what the rule also says is, if I cut a piece of cardboard the size of the palm and the fingers, the whole deal, palm plus fingers, if I cut a cardboard of this size, then it will represent 1%. So if I have patchy burns, I cut the patient's palm and hand size cardboard, this much size. That represents 1%. So if he has patchy burns, I keep placing it and calculating. So 9 rule cannot apply everywhere. If little areas are burnt, I cut it and I keep applying. The fundamental is, it will take me my hand and my fingers to hold my genitalia. So I can hold all my genitalia with my hand and fingers. That is 1%. That's why genitalia is 1%. Okay. This is the philosophy of this calculation. Don't laugh at it. That's how he did it. This is how I have been taught also from my first MBBS. That I hold the genitalia with my one hand, so it is 1%. That's why genitalia is 1%. What they can ask you is this chart, Lund-Browder chart. Okay, this is the chart. Now, what will they ask you? They will not ask you to calculate it. Hi-fi. What they are going to ask you is what varies according to age. What will vary according to age in this chart? Because if you see, arm, whether it's a child or an adult, is the same. Genitalia is the same. Neck is the same. Trunk is the same. So every component is not changing. When I'm seeing the chart, I am seeing only 3 components. I am seeing head. Head varies with age. In a small child, how much head is? In an adult, how much the head occupies? Second is thigh, and third is leg. So the variation according to age in this chart is going to be for head percentage, thigh percentage, and leg. They change with age according to the chart. So I use the chart for calculating based on age, bones in the thigh, leg, and face. Others are going to be the same, irrespective of age. Okay, so this is the core of this chart that you need to know. What varies with age in the Lund and Browder chart? Thorax, abdo, upper limbs, neck, perineum doesn't change. All right. So no need to mug this chart. If you want, you can, but it's not mandatory. All right. If I set your paper, I would put this image. If it were to me, I would 100% put this. What organism is being diagnosed using this? This is my question. Means I would put this because it's the kind of thing students don't see. They don't know. If you have not seen it, you won't know it. Is it C. jejuni, H. pylori, Clostridium, or E. coli? And the second part is, what sample do I use? What is the tissue or sample for doing this test? If you want, I'll give you option. You choose, you measure it from the person's breath, from his serum, from his gastric mucosa, or from his feces. What is the sample for doing this test? Yeah, it is H. pylori. Absolutely right. It's an H. pylori rapid urease test. It tests the urease activity of H. pylori. What sample do I put to gauge the positivity of the result? Do I put his breath, serum sample, mucosa sample, or feces? We never think like this, isn't it? Okay, breath is A, serum is B, gastric mucosa is C, and feces is D. You only like A, B, C, D, right? If I put anything else, then you start wondering what's happening. Okay, gastric mucosa or breath. Please understand how you put his breath on this. Let's not do it like that. The sample that is used is gastric mucosa. Okay, it's not breath. Breath cannot be put. Urease breath test is different. You breathe into a machine and the machine says urease activity yes or no. Okay, like how you have alcohol breath test, that's how you have urease breath test. So this is not urease breath test. This is a rapid urease test. What I have to do is I do an endoscopy and I take a biopsy of the antral mucosa. Antral mucosa. I take a piece of the mucosa and I place it on the slide. If it becomes pink or red, that means there is urease activity present. If it does not change color, if it remains yellow, that means there is no urease activity. That's how you diagnose. I put this, yeah, for that endoscopy is a must. It's an endoscopic diagnosis. It's diagnosed on endoscopy only, which means to diagnose this, I have to do endoscopy. I can do serum, I can do feces, but those are for antigens or antibodies. Those are not diagnostic tests. Okay, those are for antigens and antibodies. This is a test of choice for diagnosis of H. pylori. Okay, this is the test of choice, and many times they ask you what are the effects of H. pylori on the stomach. What all can it do? Yes, Apura, I am glad you are back. What are the effects of H. pylori? It can cause chronic gastritis. It can cause peptic ulcer disease, and it can cause adenocarcinoma of the stomach. All right, adenocarcinoma of the stomach. These are the three things it can cause. So they will ask you a question like this. All of these are seen in as an effect of H. pylori: chronic gastritis, duodenal ulcer, carcinoma stomach, carcinoma duodenum. Answer will be carcinoma duodenum. Okay, duodenal cancer is not seen with H. pylori because duodenal cancers as such are very rare. Forget H. pylori. Duodenal carcinomas anyways are rare. Moltoma is less common compared to adenocarcinoma. Moltoma also can happen, but adenocarcinoma is more as an effect of H. pylori. Okay, this is an important topic, important concept. Patient underwent hysterectomy 2 years back. Now she has abdominal pain, vomiting, exaggerated sounds, air fluid levels, most probable diagnosis. There are two questions here. One is diagnosis, other is next step. Please answer both the questions. Diagnosis and also tell me what will be the next step. This is how surgery should be learned, Don't run behind mugging the facts. Try to understand the fundamental principles. If you know the next step, the principle, however the question will be twisted, the answer will be right in front of you. No ambiguity. We bring ambiguity upon ourselves. When we say, sir, in biliary tree, when do we do HIDA scan? First, let us know where we do ERCP, MRCP. Then think about HIDA scan. Right? So, what is the case showing you? Patient had a surgery and now there is pain and vomiting and exaggerated bowel sounds, means the patient is having post-operative intestinal obstruction. All right, patient is having post-operative intestinal obstruction. Now, all of these can cause intestinal obstruction, but gastroenteritis, no, nothing to do with surgery. Gallstone ileus, nothing to do with surgery. They are not surgical causes. Either adhesive or paralytic. Paralytic ileus is seen after 3 days of surgery. So usually it is seen after 3 days, after 72 hours. Your patient had hysterectomy 2 years back. It cannot be paralytic ileus after 2 years, right? So answer is adhesive small bowel obstruction. Further, bowel sounds are exaggerated. In paralytic ileus, they would be absent. Right? In paralytic ileus, bowel sound should be absent. Here they are exaggerated. So it is next step. My dear, air fluid levels are already seen. So X-ray is already done. Now I'm asking you next step. Are you going to do CT? Are you going to do MRI abdomen? Are you going to do diagnostic laparoscopy? Or are you going to do wait and watch? What are your answers? What is your answer? So X-ray is showing intestinal obstruction. You think it is adhesive obstruction in the given scenario. What is your next step? Now think of it. I set your paper, I will put this question. Next step. Because I know students have done this PYQ, so they will be ready with the answer even without the options. They will say adhesive obstruction, wonderful. But there is no option. The option is, what is the problem? Why is it not gallstone ileus? There is nothing in the history suggestive of gallstones. There has to be something to say there are gallstones for you to think about gallstone ileus. Otherwise, yeah, gallstone ileus can cause the same things. X-ray will show regular striate, which is also not given here. Otherwise, they would have given regular striate on X-ray. Yeah, you are all going for laparoscopy. Everybody wants to do laparoscopy. And Apura is saying wait and watch. Okay, funda, simple funda. Very simple funda. Patient is clinically presenting with acute intestinal obstruction. Okay, clinical. He has pain, he has distension, constipation, obstipation, whatever. Clinically, you are thinking he has acute intestinal obstruction. First step, stabilize. Nasogastric tube, whatever. Electrolytes, nasogastric tube, fluids, electrolytes. Then investigate. First investigation, X-ray. Right, X-ray abdomen. Why am I doing X-ray abdomen? I just want to know, is the obstruction mechanical or is it paralytic? That's all I want to know. Is the obstruction mechanical or paralytic? I know, step ladder pattern, mechanical obstruction. Paralytic, diffuse, air and rectum, paralytic in the setting of surgery. Post-op 2-3 days, paralytic ileus. So if it's paralytic ileus on X-ray, conserve. Now come to mechanical. Patient has mechanical obstruction, X-ray on X-ray abdomen, mechanical obstruction. What is the next step? Please understand. I want to basically decide, does the patient need surgery or not? Okay, that's my decision. How do I decide? I need to know two things. One is, what is the cause of obstruction? Second is there any complication? So I need to know what is the etiology. Because before I go for surgery, I need to know what the problem is. Is there a stricture? Is there a malignancy? Is there a strangulation? I need to know etiology, and I need to know status of bowel in the form of, is there any ischemia? Based on this, I will decide surgery or no surgery, which means mechanical obstruction, CECT app. Based on CECT, you will decide laparotomy or not. All right, because in adhesive obstruction, the preferred treatment is conservative. Preferred treatment, it is conservative. But I have to decide whether I should conserve or operate. How will I decide? Based on CT. If CT shows adhesion is too much, bowel is twisted, complete obstruction, ischemia, operate. If CT shows little few air fluid levels, not much problem, possible obstruction, incomplete obstruction, conserve. Simple. Intestinal obstruction, trauma, oncosurgery are all fundamentals. Your fundamentals have to be clear. All right. Patient underwent diagnostic lab for chronic abdominal pain and diarrhea. This is what you saw. This is one of my favorite images. When I teach my undergraduate students, I always teach them these kind of things. Fascinating. Adhesive lysis only if conservative management fails. Otherwise not required. If the adhesions are few, you don't need to do adhesive lysis. If there are many, patient is in complete obstruction, you will have to do adhesive lysis. It's not a rule. Yeah. What do you see in this image? It's a beautiful image. It's never been asked. Yeah. So I will help you with this. See what the patient is having. Chronic abdominal pain, 25-year-old, some diarrhea. Why are you saying Crohn's? Is the image telling you it's Crohn's, or you saw the history? What tells you it is Crohn's? Yeah, excellent, brilliant. Good answer. So what you see here, this is a small bowel. Small bowel looks like this. And the mesentery comes from here, from below. The mesentery comes from below. This border, the opposite border, this is the anti-mesenteric border. It should be bare. There should be nothing seen there on the anti-mesenteric border. What you are seeing here is the mesentery is climbing on the anti-mesenteric border. This is called creeping fat sign. So this mesentery has come onto the anti-mesenteric side. This is called creeping fat sign. It is seen in Crohn's disease. All right, it is seen in Crohn's disease. Please understand, in Crohn's disease, or rather Crohn's disease, they will many times give you a history which will mimic tuberculosis. Crohn's and ulcerative colitis are not at all similar. Crohn's and ileocecal TB are what will confuse you. I'll tell you why. Both affect terminal ileum. So I'm telling you common things. Both will affect terminal ileum. So patient will have history like this. Some disease affecting the terminal ileum. They start with diarrhea. The first symptom in both is diarrhea. They begin with diarrhea. They progress to subacute intestinal obstruction because of stricture. They are both seen in a young population, between people in their 20s and 30s. When you will do imaging, whether you do CT or you do barium meal follow through, they will show the same thing. String sign, Sterling sign, the features are the same, ileal obstruction. When you will do colonoscopy and biopsy, you will see ileal ulcers in both. There will be ileal ulcers. And when you send it for histopath, the ileal ulcers will also show the same thing. They will show granulomas in both. There will be granulomas. There will be Langerhans giant cells. Caseation will not be there in Crohn's, but in both, the biopsy findings will be very similar. So then how do I differentiate which is what? How do I differentiate Crohn's from TB of the ileocecal region? While laparoscopy has been done, he must have been an obstruction or maybe for diagnostic purposes, because they said diagnostic laparoscopy. Means they must have done everything else must have come negative. So they would have been like, okay, let's go inside and see. Yeah. Then how do I differentiate? If they are so identical, how do I differentiate? Because I did all the tests, all the features, because mind you, treatment is the opposite. Treatment of Crohn's is immunosuppression. Treatment of TB is AKT. If you give immunosuppression and he has TB, TB will flare up. So you have to decide at this stage, how are you going to differentiate? And don't say you are going to do AFB or TB gene expert. It never comes positive. TB can also have skip lesions. TB can affect any part, right? Typically terminal ileum. We check for ASCA. ASCA is not specific. ASCA is not specific. What if ASCA is negative? What is the one test which will separate the two? Which is very sensitive. It's not specific, but very sensitive. What test will separate Crohn's disease? Yeah, excellent, Neeraj. Excellent. That's the answer. Fecal calprotectin. Fecal calprotectin is going to be seen in Crohn's. In TB, it will be negative. All right, fecal calprotectin. That's the answer. Treatment is going to be different. Treatment-wise, this is going to be immunosuppression. And for TB is going to be ATT. Right? They are not going to give you any confusion between Crohn's and ulcerative colitis because they are not at all similar. They are not at all similar. They will give you a scenario where you have to pick between one of these two. Okay? This new question never been asked. What is the most appropriate management of the finding of DU bleed in the image? This is a real world question. It's not something that you can mug. What are you going to do for DU bleed as per this image? Are you going to inject adrenaline, clipping, convert to surgery, or dual endotherapy? Yes and no answer. Either you know it or you don't. Yeah. These are the kind of questions which you will know only if your preparation is very strong. If it's not, today you will understand why. And going further for the next 20 days, you will remember this. Maybe even for INI CET. I will give you a clue. You don't need the image. Even without the image, you can give the answer. If you just see the options, you can give the answer. You don't need image. Whenever they ask you endoscopic management of DU bleed, you endoscopically what you can do, you can either inject adrenaline, or you can clip if you can see the vessel, or you can do what is called as coagulation. Argan plasma coagulation. These are the three common things which are done. The best treatment is going to be combination, combine any two of these. So answer is dual endotherapy. All right, answer is dual endotherapy. This is the treatment of choice for duodenal ulcer bleed. Means this and this. Two things have to be done. Not just one thing. Even if one thing stops, you still do something else. Two things have to be done. Dual endotherapy. Laparotomy will be done only if patient is unstable. Means you can't do endoscopy, he is unstable, or endoscopy has failed. Failed endotherapy, you will do laparotomy. Right? So that is about duodenal ulcer bleed. Again, an important concept. Neonate presents with bilious vomiting few hours after birth. Which of these is not an expected finding? At the end of this session, I think I'll take another 10 minutes more maybe. I'll give you a list of what are the must-know things in surgery. Most of which I have covered, but what else that you need to do? Which of these is not an expected finding? If I set your paper, I will 100% put a question on something on neonate intestinal obstruction. Basically, this is asking about neonatal intestinal obstruction. Which of these is not an expected finding? Triple bubble, abnormally placed colon, Down syndrome, red currant jelly stool. Why are you saying red currant jelly stools? What's the purpose of this? Some are saying A, some are saying D. Down syndrome is expected in a child with bilious vomiting. I want to know why you guys are saying A or D. Because you can I hope it's not one person copying the other just because my friend Neha said A. That's why I have also said A. Let it not be like that. Let there be some principle. Okay, before you reach the principle, let me see how you think. Child is presented with neonatal intestinal obstruction. That is the concept. Whenever they give you a tough question, no, you see from what topic the question has been picked. Question has been picked from neonatal intestinal obstruction. Bilious vomiting means that he's obstructed. Why would a neonate start throwing up? Now, what causes neonatal intestinal obstruction? Why is the child born with it? There are a few reasons you need to know. One is intestinal atresia. If the intestine is not formed only, intestinal atresia, like most common type is duodenal atresia. Duodenal atresia, jejunal atresia, or ileal atresia. Duodenal atresia is the most common one between the three. This is typically seen in Down syndrome. It is also seen in a disease of the pancreas, that is annular pancreas. Yes, absolutely right. Chinna has said annular pancreas. In that also you can get duodenal atresia. They will all cause bilious vomiting. The second cause of neonatal intestinal obstruction is meconium ileus. Cystic fibrosis, meconium ileus. It is seen in a child with cystic fibrosis. Third can be midgut volvulus. Midgut volvulus, and fourth is Hirschsprung. But Hirschsprung can present at any age. So Hirschsprung. These are causes of neonatal intestinal obstruction presenting with bilious vomiting. Okay. Infantile pyloric stenosis, IHPS, typically presents at 4 weeks, 4 to 6 weeks, and it presents with non-bilious vomiting. Okay, this is clear now. So when I think of this disease, I think of these diagnoses. So Down syndrome possible, duodenal atresia, abnormally placed colon, midgut malrotation. Triple bubble sign on X-ray, jejunal atresia. Right, jejunal atresia. Red currant jelly stools, which is seen in intussusception. Intussusception is not a neonatal problem. It's a problem of a child, 6 months to 1 year. Weaning period. So weaning period intestinal obstruction is going to be intussusception. All right, it is going to be intussusception. If your fundamentals are like this, I guarantee it. If they ask 25 questions in surgery, 22 questions you will get right. This is the fundamental that you need to have. If you didn't have it, now you have it, because I am touching on the most important topics. The most important topics. All right. So please digest what I just taught you about neonatal intestinal obstruction. A few landmarks that you need to know about laparoscopic inguinal anatomy, because someone was asking, teach about hernia. About laparoscopic inguinal anatomy. Now, I'll just give you briefly what you need to know, what can come in the exam. When I'm doing laparoscopy, okay, let's assume the patient is lying down like this. This is the head of the patient. Somewhere here is the pelvis or the pubis. All right. Now, if I go layer by layer, here will be the muscle layer. Over here, this is the muscle layer. Underneath it is going to be the peritoneum, and underneath it is going to be the intestine. Right? I'm going to see the intestine. Dr. GRG is also here. Thank you, sir, for being here. It's my honor. So I am going to have the orientation like this. When I am doing a laparoscopic inguinal hernia surgery, I can start in 2 ways. One is I cut the skin, cut the muscle, cut the peritoneum, go inside it, intra-abdominal. Look at the peritoneum on top, cut the peritoneum, and enter this plane like this, and operate over here. See the hernia here and operate. So I have gone through all the layers into the abdomen, seen the peritoneum on top, cut it, and gone in this plane. This approach is called PAPP approach, transabdominal pre-peritoneum. Go through the peritoneum, see the peritoneum on top, intestines below, cut it, go in the preperitoneal plane. The other approaches don't go inside the peritoneum. Easier approach, cut the skin, cut the muscle, don't cut the peritoneum, reach only till here, and remain in the preperitoneal plane and do the surgery. That is called TEP, totally extraperitoneal. In both the techniques, my surgery is always going to be pre-peritoneal. All right, it is going to be pre-peritoneal. Just the start is different. In TAP, I started in the abdominal cavity, saw the intestine, saw the peritoneum, cut, went pre-peritoneal. In TEP, I am not entering the abdominal cavity. I am totally in this plane, pre-peritoneal from the start. So what I am seeing is this area. Above are the muscles, above is the fascia transversalis, below is the peritoneum. This is how I reach the inguinal region. Now, with this understanding, see this image. What I am seeing here in this image, this is the midline. All right. And this is the right side, this is the left side. This is the right side of the midline. At the top is the fascia transversalis. Below, over here, is the peritoneum. All right, fascia transversalis on top, peritoneum below. If I poke into this peritoneum, I'll enter the intra-abdominal cavity. I'll see the intestines below. So right now I'm pre-peritoneal. The first thing that I see is this structure which goes from the pubis all the way laterally to the ASIS over here. This structure is your inguinal ligament, which is also called in laparoscopy iliopubic tract. Iliopubic tract simply means inguinal ligament. So I see the inguinal ligament over here. This is the first landmark. Now see up. Now see at the roof. At the roof, I see these two vessels running over here. This is my inferior epigastric vessels, inferior epigastric artery and vein. All right. So inferior epigastric, I see at the roof. This is the most important part. If I see a hernia medial to it, this is going to be direct hernia. If I see a hernia lateral to it, it will be indirect hernia. So when I do laparoscopic hernia, I see direct and indirect based on medial or lateral to inferior epigastric vessels. In open hernia, I don't see inferior epigastric vessels. In open hernia, I am above. Inferior epigastric vessels are very deep. I don't see them. Here I am seeing them. Here, this tells me it's a direct hernia because it's medial. Indirect hernia is lateral. Any other hernia I can see apart from direct and indirect in this image? So direct will be medial, indirect will be lateral. Any other hernia I can see? Have a look. See if you can find any other hernia. Now, this is the deep ring. Through the deep ring, the cord structures will form and they'll enter the inguinal canal in front and become the spermatic cord somewhere in front. Okay, so they enter the deep ring, enter the inguinal canal and become the spermatic cord. Now, how are they becoming the spermatic cord? This is the vas deferens, which is medial. This is the testicular vessels, which are lateral. So this triangle that I see over here, which is formed by the vas deferens and the testicular vessels, which contains the iliac vessels. This is called triangle of Doom. All right, this is called triangle of Doom. Now you can see clearly why it is triangle of Doom and how it is formed. It is formed by vas deferens medially, testicular vessels lateral. What it contains? Iliac vessels. That is triangle of Doom. Lateral to this triangle over here in this plane, where I have testicular vessels medially and iliopubic tract lateral. This triangle, which contains testicular vessels medially and iliopubic tract laterally, this is called triangle of pain. Why is it called triangle of pain? It contains a lot of nerves. The most important nerve that it can traumatize is the lateral cutaneous nerve of thigh. Okay, lateral cutaneous nerve of thigh. If it gets traumatized, he gets pain, chronic pain in the thigh. So this is the orientation of triangle of pain and triangle of doom. The third hernia that I can see will be, if this is the inguinal ligament, it will be below, over here. Hernia below the inguinal ligament, that is femoral hernia. So when I do laparoscopic hernia repair, I can treat direct, indirect, and femoral hernias together. All right, that is the message. All the three hernias can be treated together. Okay, few more questions. Important question. They have asked this many times. They will keep asking it till enough students get it right. So I hope now you guys know this topic well. Patient presents with history of varicose veins. He has some findings over here. Some ulcer which healed 2 months back. According to the CEAP, what is the C stage? Yeah, what is the C stage according to CEAP? C4A, C4B, C5, C6. What do you see in this image? I hope you don't make a mistake. Some topics like CEAP, Glasgow Coma Scale cannot make a mistake. Okay, they will really break your rank. So you have to focus on the clues in the question. Brilliant, I'm happy. Many of you have given the correct answer. Good job. It is C5. Please understand, the image is just to fool you. Okay, the image is just to fool you. He has a ulcer which has healed. You always look at the higher grade. Healed ulcer is C5. And active ulcer is C6. And what is C4A, C4B? And what do you see in this image? Forget the fact that the ulcer has healed. What do you see in this image? And what is C4A and what is C4B? Yeah. I don't want to be at a stage where you need to be taught CEAP because it's too important. It's one of the must know things. Yeah. What is C4A, C4B? And I'll give you a trick to remember. Some simple trick. I'm sure there are many awesome people who teach you awesome mnemonics. But I am not one to teach you mnemonics. I am one to teach you fundamentals. C4 pigmentation. Okay. So C4A are skin changes which are early. Early skin changes like pigmentation and dermatitis. C4B is advanced skin changes, that is lipoderma sclerosis. Okay, lipoderma sclerosis. C3 is edema and C1, C2 are varicose veins. Now I'll give you a very simple way to remember. C1 and C2 are uncomplicated. Okay, there are no complications. There are just varicose veins. C3, C4 have skin changes. You can take a screenshot of this if you want to. I'm sure you have notes for this also. And C5, C6 are related to ulcer. That's how I remember it. So the first battle is won. C1, C2 varicose veins, C3, C4 skin changes, C5, C6 ulcer. So at least some categories are ruled out. And then you go deep and say, okay, C3 is edema, C4A is pigmentation, C4B is LDS, and C4C is coronaphlebitis. That's where they will catch you. And remember, if it's asymptomatic, you add the suffix A. And symptomatic, you add the suffix S. So if there are symptomatic varicose veins, it will be C2S. Asymptomatic will be C2A. All right. Few extra points because I love asking these kind of things. Please tell me what is this image, first one, and what is this image? This expected image on an expected topic. Either they will give you an image or they will give you a question on this topic for sure. I am waiting since a couple of years for this topic to be asked because it is one of the most important topics in general surgery. So what do you see in this image here and what do you see in this image here? This one is quite easy, the second one. So please tell me image A and image B. What are they doing in varicose veins? Yeah. Come on, come on. Wonderful, wonderful. Please see. Active laser withdrawn along the length of vein. This is the laser probe. which has been put into the great saphenous vein, which will go all the way till the SFJ. So this is endovenous laser ablation. Endovenous laser ablation. In today's day and age, it is the treatment of choice for varicose veins with SFJ incompetence. It is the treatment of choice. This is easy. This is foam sclerotherapy by the technique of pessary. Okay, this is pessary technique of foam sclerotherapy. And the last one, again an expected topic. After this, I'll give you the list of IMPs, but this is an expected topic. It's PYQ. I had predicted this topic. It was there on my Telegram also. They had put the same thing a few months back. This is INICET 2022. This was one of the predictions which came to. I feel even in NEET PG, this will come again. This came in INICET last year. Patient presents with swelling on the neck. When she eats food, the swelling worsens. You see some, they had given an ultrasound image. Okay, the image given was ultrasound. I have an X-ray image. What is the finding? This is cyalolithiasis or submandibular calculi. Okay, submandibular calculi. What they tell you is this: when she eats food, she gets pain and swelling. What is this called? Whenever you eat food, you get pain. What is it called? This is a question. It's there on my Telegram much before NEET. This is called meal time syndrome. You know, the problem that happens with us is we study so much of GI, HPV, oncology, trauma that we lose out on general surgery. We lose out on head and neck. Head and neck are the easiest questions which seem the most difficult because we have never studied them. If you don't study them, you will miss out on such easy, straightforward questions. This is mealtime syndrome. So what happens is the submandibular gland is over here and its duct, the Wharton duct, has a anti-gravity drainage. It goes upwards. So many times you get stones in the submandibular duct over here. So what happens is when she eats, the duct gets blocked by the stone and the secretions will increase because it stopped and she's eating, and the gland will swell. So she gets a swelling whenever she eats, swelling with meals because the duct is blocked. And the swelling subsides when you stop eating, usually 1 to 2 hours after meals. The swelling goes. That is mealtime syndrome. A feature of submandibular duct calculi. How are you going to diagnose? Diagnosis is simple. You are going to do ultrasound of the gland, ultrasound of submandibular gland. What I expect to be asked now is the treatment. This is what they will ask next. They asked about the diagnosis. Now they are going to ask treatment. Now, what is the treatment going to be? Treatment is on two fronts. Treatment depends on the size of the stone. If the stone is up to 4 millimeters, you are going to do endoscopic removal with Dormia basket. Okay, you don't have to do surgery. Endoscopic removal with Dormia basket. It's like ERCP. How in ERCP you remove the stones? Same way you can do endoscopy of the duct. So that is coeloscopy. And you remove the stone with Dormia basket. If it is more than 4 millimeter, you are going to do lithotripsy, followed by endoscopic removal. Lithotripsy means you will break the stone. So you do lithotripsy, you break the stone, and then you do endoscopic removal. So this is about submandibular stone management based on size. All right. So I have tried to cover a lot of important topics. You can go through this again. This is the site. This is the place of must know topics. You can take a screenshot of this. This is the first half. Okay, you can take a screenshot of this, or you can go through the presentation again. You can go through the video again. So this is list of must know topics part 1. And this is list of must know topics part 2. All right. If your plan is I am going to give one more day to surgery, just one more day, because I have to revise other subjects, these topics have to be touched upon. Okay, they have to be touched. You cannot run away from them. This is like the gold mine of general surgery. They are very new, very popular. and they have been asked very recent. Okay. If you enjoyed the class, do give a thumbs up. You can join me on Telegram or Instagram if you have more doubts. I will always be there to help you. No worries. And I hope to see you for more sessions in the near future. All the best for your exams. Study well and study hard. Thank you, guys.